Namaste and a very good morning to one and all present here today. We will begin today's session with the paper presentations from the senior category of the winners. The first speaker today, we have Dr. Monica. I request Dr. Monica to kindly share her screen and start her presentation. Dr. Monica?
Yes, I'll be sharing the screen. Is it visible?
It's visible.
Can I start my presentation?
Yeah, you can start sharing your screen.
Can I start the presentation?
Yes, sure. You can start your presentation.
Yeah. Good morning, all. I'm Dr. Monica from Rangadore Memorial Hospital, and today I'll be presenting my paper on assisted vaginal birth, contemporary trends in a tertiary care center. So assisted vaginal delivery is an important tool in obstetrics, but unfortunately is becoming a dying art nowadays. Careful selection of cases and appropriately trained personnel are important to ensure optimal outcomes. So the aims of our audit were to analyze the causes of instrumental delivery and to look at the maternal and fetal outcomes. It was done as a prospective case notes review of all the instrumental deliveries over 12-month period from February 2020 to January 2021. Various parameters like maternal demographic characteristics, antenatal risk factors, labor and delivery details, maternal and fetal complications were noted. We had a total of 1,084 deliveries, of which 67% were vaginal deliveries. And when we look at the split up of this, around 50% were normal vaginal deliveries, around 10% ventouse, 5% forceps, and 1% sequential instrumental deliveries. Coming to the subgroup of instrumental deliveries, we had 170 cases, which accounted for 15.6% of all the vaginal deliveries and 23.4% of all vaginal deliveries. And majority of them were ventouse deliveries. When we looked at the maternal characteristics like parity, we found that majority of them, around 92% of them were primigravida. And among the multigravida, half of them were previous LSCS cases who had a VBAC delivery, which accounted for 4.1% of all the instrumental deliveries. When we looked at the mode of onset of labor, we found that almost an equal number of them had spontaneous and induced labors, because we normally expect induced labors to be associated with more interventions. And when we looked at the antenatal risk factors, we found that pre-labor rupture of membranes was the most common risk factor, followed by GDM, past days, IUGR. Previous LSCS accounted for 4.1% of the cases, and high BMI accounted for around 3% of the cases. We found that around 64% of them had taken epidural analgesia, which can be considered as a common risk factor. And we also found that almost 22% of them had no risk factors, but still ended up having an instrumental delivery. So as I already said, around 64% of them had taken epidural analgesia. When we looked at the indications, CTG abnormality was the most common indication, followed by maternal exhaustion and prolonged second stage. Majority of them, around 88% of them, were conducted in the labor room, and around 11% of them as trial of instrumental delivery in theatre, keeping everything ready for cesarean delivery. These were the cases where we anticipated failed instrument, as in high station or inadequate incomplete rotation. So ventouse was the most common type of instrument used, followed by forceps. When we looked at the ventouse deliveries, we had 104 cases which were successful, and majority of them required single application and single pull. Only 16 cases needed more than one application. We had 11 cases where ventouse was applied but failed, leading to sequential instrumental delivery. So the failure rate was around 9.6%. We had around 55 cases of forceps deliveries, all of which were successful. There was no failed forceps leading to sequential or cesarean delivery. Most of them required single application and single pull. Only in one case, we had to reapply the forceps after reassessing the position. We had 11 cases of sequential instrumental delivery. All of them were ventouse followed by forceps, and 3 among them were conducted as trial of instrumental delivery in theatre. The reason for failure being caput, the reason for failed vacuum being caput, poor maternal effort, or vacuum pop-off. Most of them did not have any maternal or fetal complication. Only one baby needed NICU admission, only one case of 3A tear. We had 8 cases of rotational deliveries, accounting for 4.7% of all the cases, 4 cases of manual rotation followed by forceps, 3 cases of vacuum rotational delivery, and 1 case of vacuum rotational delivery, which ended up as sequential delivery. When we looked at the maternal outcomes, we found that almost 64% of them had no complications. Around 10% of them had 3rd degree tear, and 70% of these were due to vacuum, and 30% due to 70% due to forceps and 30% due to vacuum. And we had the vaginal lacerations in 8.2% of the cases, which were found equally between the forceps and vacuum group. Only one case of traumatic PPH. Atonic PPH accounted for around 21%. Only 2 cases of PPH of 1.5 liters. No cases requiring blood transfusion or HTU admission. When we looked at the neonatal outcomes, almost 88% of them had no fetal complications. Only 9 babies needed NICU admission. Around 4.7% of them, shoulder dystocia accounted for 4.7%. Only 1 baby had neuropraxia, which recovered well on follow-up. Cord gases were documented in all our cases, and in 84% of them, it was found to be normal. Only 1 baby had a arterial pH less than 7.1, but this baby cried and it was shifted to mother side. And when we analyzed the cases where the duration of second stage was more than 2 hours, we had around 21 cases. More than half of them had taken epidural analgesia. Majority of them were delivered by forceps, and none of them had sequential instrumentation. We had 5 cases of third-degree tear and 3 cases of shoulder dystocia, no other major maternal or fetal complications. So to summarize, the rate of our instrumental delivery was around 15.6%, majority of them being venous deliveries, and a vast majority of them, around 92% of them were primigravida. So we were successful in reducing the rate of primary cesarean delivery. Around 64% of them had taken epidural analgesia, so it can be considered as a risk factor for instrumental delivery. We had around 11% trial of instrumental in theatre, around 5% rotational deliveries, and around 5% of NICU admissions. When we look, compared to our previous statistics, the rate of our instrumental delivery has reduced from 24 to 15%, and NICU admissions from 7.8 to around 5.3%. So our rates are on par with the international standards. RCOG recommends a rate of 10 to 13%. Our outcomes also in terms of failure rates and complications were much less compared to the international rates. We had no failed trial of instrumental delivery. We have achieved these rates by better management of second stage. So proper selection of cases and proper selection of instruments is essential to reduce the failure rates. Training and supervision is essential to optimize the outcomes. Cord gases has to be done in all the cases. Documentation and ongoing audit review is very essential to optimize the outcomes in instrumental deliveries. Thank you.
Thank you, Dr. Monica, for that beautiful presentation. Our next speaker for today, we have Dr. Manjulata Verma. I request Dr. Manjulata Verma to kindly share her screen and start her presentation.
If my screens are visible, good morning.
Good morning, ma'am. Yes, ma'am. Your screen is visible, ma'am.
Okay. So very good morning to all. Greetings from Lucknow.
Ma'am, your video is visible. Your screen is not shared, ma'am.
Okay, just a minute then. Is it now visible?
No, ma'am. Yes, ma'am. It's visible now, ma'am.
Okay. So very good morning to all and greetings from Lucknow. Myself, Dr. Manjulata Verma, and I'll be speaking on a critical appraisal of maternal-fetal outcome of antenatal heart disease patients at Tertiary Care Center of Northern India. And this is a study from the King George Medical University, Lucknow, Uttar Pradesh. So as you all know that pregnancy in a heart disease patient is a high-risk pregnancy, and definitely risk is increased for both mother and fetus in a heart disease patient. And extent of this risk depends on the type of heart disease and associated complications. Multidisciplinary approach, that is collaboration of a team of trained obstetricians, cardiologists, anesthetists, pediatrician results in the successful outcome for mother and child in majority of the cases. So the aim and objective of my study was to critically appraise the maternal-fetal outcome in pregnant patients with heart disease. This study was done in the Department of Obstetrics and Gynecology, King George Medical University, Lucknow, in the duration of 1 year from January 2018 to December 2018, and it was a prospective study. Baseline data in terms of age, parity, gestational age, cardiac lesions, ECG, echo assessment of left and right ventricular systolic function, Carr-Craig scoring was done. Diagnosis of the heart disease, course in the hospital, management, maternal and fetal outcomes were followed. So when we look for the results, we had total 9,360 deliveries in 1 year period, out of which 120 patients had heart disease. So incidence of heart disease was 1.28%. The mean age of these patients was found to be 26.7 years. And when we look for distribution, it was found that maximum 56 patients out of 120, 56 patients, that is 46%, were from the age group of 25 to 30 years. This is a very remarkable thing which we found in our heart disease patients, that unbooking of pregnancy is still a major concern. 88 patients out of these 120, that is 73% patients, are unbooked, unsupervised pregnancies even at present. When we look at the symptoms distribution, out of 120, 3 patients were in NYHA 1. Maximum patients were in between 46 in NYHA 2, 44 one in NYHA 3, and 7 patients were in NYHA 4. Maximum patients, that is 57 patients, had complaint of palpitation, 5 had fever, 6 had pedal edema, 5 presented with recurrent chest infection, 2 patients had hemoptysis, 25 had cough with sputum, 6 had chest pain, 8 patients had orthopnea, 3 had PND, and out of these 120, 3 patients were asymptomatic, which were found to be having heart disease on regular workup. So this slide is showing about the timing of the diagnosis of heart disease. Out of these 120 patients, 4 patients had congenital heart disease, 47 were diagnosed in their non-pregnant state, 9 patients were diagnosed as heart disease in their previous pregnancies, and these many 55 patients were diagnosed in the current pregnancy, out of which 10 patients were diagnosed as heart disease in the first trimester, 16 were diagnosed in the second trimester, and 29 patients were diagnosed in the third trimester. 10 patients were diagnosed as heart disease in the postpartum period. Now, types of heart disease, most common, 84 patients were having RHD, rheumatic heart disease. 6 patients had dilated cardiomyopathy, and followed by 11 patients had postpartum cardiomyopathy. And 9 patients had congenital ASD. We had 1 patient who had Eisenmenger syndrome. 1 had RHD with ASD combination. 2 patients presented with MIA. 1 patient had WPW syndrome. 2 had TOF, and 1 had idiopathic PAH. Now, this slide is showing about the Karprig scoring. Karprig scoring basically is for prediction of the heart disease morbidity and mortality, which includes 4 things and gives 1 score each, like if their history of prior cardiac event in form of heart failure, TIAs, infarction prior to pregnancy, or arrhythmias, NYHA class more than 2, or cyanosis. Left heart obstruction, mitral valve area less than 2, aortic less than 1.5, and LV outflow gradient more than 30, and reduced systolic ventricular function. So in my study, out of 120, 38 patients had Karprig score 1, 24 had 2 Karprig score, and none of the patients had Karprig score 4. Now, mode of termination, out of these 120, 61 patients had cesarean section, that make 50% of the patient, and rest patients had vaginal delivery, out of which 33 patients had 29 patients had full-term vaginal delivery, and 33 patients, that is 27% patients had preterm vaginal delivery, and 6 patients out of 120 needed suction evacuation. Now, on the fetal outcome, out of 120, 33 patients had preterm vaginal delivery, 27% that makes, and 30.8%, that is 31% patients had a complication in form of low birth weight. 55 babies needed an ICU admission, and we had 10% perinatal mortality in our study. When we look for maternal morbidity and mortality, our 25% patient had progression of NYHA during their pregnancy from 2 to 3 or from 3 to 4. 10% patients had congestive heart failure during pregnancy. Out of 120, 29 patients were shifted to ventilatory unit for further management. 2 patients had mortality. 1 patient, she had NYHA 4. She was a case of postpartum cardiomyopathy. She had progression of NYHA. She had CHF. She had global hypokinesia. Ejection fraction was 38%. And her Karprig score was 2. We did cesarean at 37 weeks, but a patient could not be salvaged. And second patient, she also presented with NYHA3 with subaortic VSD and Eisenmenger syndrome. Her ejection fraction was 38%. She landed up into cesarean at 34 weeks. Her Cartwright score was also 2. That patient also had mortality. So take-home message from this study is that for having a safe mother and safe fetus, we need to have 100% booking of antenatal patients, especially with heart disease. These patients need good antenatal care with multidisciplinary approach, and early diagnosis must be is preferable before pregnancy for a good outcome. Thank you so much for patient listening.
Thank you, ma'am. Thank you so much for your excellent presentation. Our next speaker for today, we have Dr. Prakriti Prakash. I'm requesting her to kindly start sharing her screen.
Okay, I'm sharing the screen now. Okay.
Yes, ma'am.
Is it visible? Yeah.
Yes,
Hi, myself Dr. Prakriti from Rangadhara Hospital, Bangalore. I'm here presenting an analysis of incidents in OBG department, which says there is a need for a robust risk management process. So coming to what is an incident. An incident is an event that can cause harm to the patient, or they are the near misses which have a potential to cause harm to the patient. They're more often unexpected and traumatic to the people who are involved in the incident. They have a significant effect on the patient outcomes and has a huge impact on medical problems. Hence, we need to review every incident which happens in the department, and we have to develop our own risk management process so that we learn from it and so that we can avoid the recurrence. So we have a trigger list for incident reporting in maternity. Coming to maternal incidents, we have a list starting from the maternal death, shoulder dystocia, PPH of more than 1.5 liters, anesthetic complications, including even third and fourth degree tears. In the neonatal incidents, we have stillbirths of more than 500 grams, IUDs, and all-term NICU admissions. Coming to organizational incidents, any fault in the equipments or medication error, retained swab, and violation in the local protocols will come into the organizational incidents. So aim of our study was to analyze the adverse events which occurred in the department and to look at the processes and plan strategies how to improve upon it. So we made an audit over a period of 15 months where we gathered the data from incidents in the registers and we reviewed case notes for any further details were required. So here we have a format for incident reporting where in the first page we have to mention a date, time and place of event. And we have a list for the general incidents, where the drug errors, fall in the bathrooms, blood product related issues will come into the general incidents. And we have an exclusive list for the obstetric related incidents. And in the next page, we mentioned the personnel who were present during the incident. And we summarized the incident which happened. And at last, after reviewing and analyzing, we write what action, if anything, could have been taken to prevent this incident from occurring. So coming to the results, the total number of deliveries were 1,321, and among them the incidents reported were 44. And we found that equal number of incidents were not reported, that is 44 again, and 36 NICU admissions. So totally analyzed incidents were 124. Incidents at a glance. PPH, we had 7%, cord collapse 2%, term NICU 38%, shoulder dystocia 10%, ICU admissions were 2%, sequential instrument 9%, third degree, fourth degree tear were 6%, stillbirth we had 2%, anesthetic events were 9%, and miscellaneous was 15%. Accidents, we did not have any, and never events were 2. Never events are those events which should never occur, and among them we had two. One was a maternal death who had a massive PPH in spite of needing medical surgical management, including hysterectomy. She had a multiple blood transfusion. She went into DIC with disproportionate blood loss, so we suspected amniotic fluid embolism in that. At last, she had a ventricular tachy, and we couldn't revive her. So even though we thought it was not avoidable, but we had so many learning points from this regarding the preparedness of a multidisciplinary team and having a blood bank on site. Now we have made a MOU with a neighboring blood bank. So we have a 24 hours availability of the blood. And we had some lacunae in the documentation where we noted and we noted the corrections. And then we had one retained swab. which was noted 1 hour after the instrumental delivery. After this incident, we started documenting all the swab count, even after the vaginal deliveries as well. So next was PPH9. We reported all those with the incident, with the estimated blood loss of more than 1.5 liters. Many were atonic and 2 were traumatic PPH, and 2 were placenta accreta. Many were managed medically and few needed Bakri and PPH cannula. Hysterectomy was one done in elective case of placenta accreta. The learning points we had from this: we do conduct ongoing PPH skills and drills for all medical staff, including nurses. And we have made an emergency obstetric kit, which includes all the required things, starting from vacutainers, cannula to the Bakri balloon and PPH cannula into one kit, where it is handed over every shift with its completeness, and blood bank on site. And shoulder dystocia, we had 12. Among them, more than half were instrumental delivery. And maternal complications, very few had a PPH and 3rd degree tear. And one baby had a neuropraxia, which recovered well, and one perinatal depression also had a good recovery. Many we were able to deliver with macrobuds and suprapubic, and 2 needed a rotational maneuvers. Again, ongoing skills and drills will be conducted periodically for shoulder dystocia as a part of emergency obstetric training. And coming to 3rd degree and 4th degree tear, we had 8. 6 of them had an instrumental delivery. Few risk factors we noted here was occipital-posterior position shoulder dystocia. 1 had a prolonged 2nd stage. And the learning points, again, skills and drills on the instrumental delivery will be conducted regularly. And we train staff regarding the perineal support, and we ensure that the episiotomy is given at the proper angle. Term NICU, we had 64, which comes to 5.54%, which is in par with the standards. Only 1 baby had a neonatal death who had a esophageal atresia and died because of sepsis. And causes, many were because of meconium aspiration. And we do conduct perinatal meeting every 6 weekly and discuss among all those NICU admissions. Anesthetic complications were 11, 50% were because of the failed spinal who were converted to GA. We found that obesity and some technical errors were the risk factors in that. And 25% had a PDPH. So we have made sure now the anesthetic review will happen to all those risk patients at the clinic and at the admission time, and we have a combined review meetings. Sequential instrumental were 11. All of them were ventouse failed by forceps, and many were done because of CTG abnormality, causes mainly because of big caput and vacuum pop-off and poor maternal efforts. And here only 1 baby was admitted to NICU, and 1 mother had 3A tear, and PPH was less than 1 liter among them. The training on the right choice of the instruments and supervising all instrumental deliveries in the juniors, and its ongoing audit. Cord prolapse, we had 3. 1 was anticipated in multi-polyhydramnias. 1 was a admitted lady in 28 weeks PPROM. So learning points were, again, the skills and drills will be conducted regularly as a part of emergency training. We have made a cord prolapse kit where everything is available at one place. And IUDs, we had 2. 1 was in booked lady, diabetic, and who had come with decreased movements and had IUD. 1 was unbooked, was referred as a fetal brady, and by the time she reached hospital, it was already IUD. Learning points, audit on medical management of diabetes, and we do educate women on the importance of fetal movements by providing them leaflets. ICU admissions were 2. And 1 was peripheral sepsis, who was resuscitated and managed and recovered well from ICU. 1 was elderly, severe hypertension, needed many antihypertensives, and she was on non-invasive ventilation. We were supposed to terminate pregnancy. Miscellaneous, 1 was sterilization, where we were failed to do a sterilization in spite of having a consent form where it was misplaced. It was a communication error. And 1 was a severe APH in primary 28 weeks with central placenta previa. And we had an emergency section, but baby succumbed because of severe prematurity. Undiagnosed breech were 2, birth trauma, humerus fracture during elective section for breech, recovered well. And delayed section were 13, and CAT 1 section were 13, which delayed more than 30 minutes. That is because most of them were presented to emergency, and we took time to stabilize her and transfer to OT. Discussion. Coming to the discussion, in spite of having systems in place, we found that equal number of incidents were unreported. And it's very important that we educate and bring that awareness among all the staffs in the team, and empowering even the nursing staffs in incident reporting, and displaying the trigger list at various corners in the hospital, like even the wards, including labor ward, OT, even the wards. We need to place the trigger list so that we know what are the incidents to be reported. And ongoing review of the incidents has to be done based on the severity, whether it is monthly, weekly, or maybe if it is a very severe incident, we have to do the next day itself. So analyzing incident reporting is one of the way of analyzing the incidents. So identifying the incidents, identifying the contributing factors, and devising a plan of action is required. Raising awareness and learning from it is the most important. And coming to the conclusion, clinical care and healthcare in the healthcare system is never risk-free. Incidents do occur. It's important we introspect with every incident and we improve upon, so that we can avoid its recurrences, or at least decrease the severity if it happens the next time, as the patient safety is at the most important. Thank you.
Thank you, ma'am. The winners for the free paper presentations, the Mrs. Vidya Basin award-winning paper goes to Dr. Prakriti Prakash. Congratulations, ma'am. And we also have the second and the third place in the senior category. In the second place, we have Dr. Lata Verma. Congratulations, ma'am. And in the third place, we have Dr. Monica Reddy. Congratulations, ma'am.
Thank you.
Hello. Hello. Hello.
Hello, ma'am. We are here.
Congratulations, Prakriti and Manjulata madam. How are you?
Thanks a lot, ma'am.
It was a nice
thank you so
study.
much. Yeah.
I had. So what was your, I mean, just for chit chat, what was the most important type you got in that?
What was the most important?
Incident, like immediately to interfere. Hello?
Ma'am. Yeah. I mean, the PPH, we were all, in most of the cases, we used to be prepared if there are risk factors in that. And shoulder dystocia, as we get many diabetic ladies, there is an increased number of inductions in our institute. So most of the times we'll be prepared, but at least when, we have a periodic skills and drills, ma'am, training for all the medical staffs, including the nursing. So it's it's been useful for us.
Abruption, rupture uterus, no.
Rupture uterus, we had one in the placenta accreta. We had 2 cases. One was which we had detected antenatally. The other one was intrapartum.
Dr. Jasmina, we are very sorry for the interruption. We have to announce for the next session also. Please excuse us, and my uncle is going to announce regarding this other sessions also. Okay, fine.
Okay. Thank you.
Thank you. Thanks a lot.
Thank you, ma'am. For the poster presentation, we have Dr. Katiki Priyanka. The winner for the poster presentation is Dr. Katiki Priyanka. We'll be resuming our session at 9 a.m.
यही लोग हैं तुम्हारे साथ ना, डॉक्टर अन्नाजा और डॉक्टर शंकर जयकिशन हर्षिता बदला। वीडियो स्टार्ट करना है तुम्हारा ऑलरेडी।
छोड़ो ना उसको, तुम अभी काटते जाओ। हाँ, कैसे करें?
हाय, गुड मॉर्निंग।
हेलो, गुड मॉर्निंग।
Good morning,
Good
ma'am.
morning, madam.
गुड मॉर्निंग सर।
Good morning.
हेलो।
Yeah, hello. हाँ madam, audible. You are audible.
ओके
You are audible, madam.
ओके।
Anjana, madam.
Yeah.
Yeah. I could see you.
Yeah. I can also see.
Mamta,
Am I audible?
Mamta has joined. Yes. Yeah.
Hello. Good morning, Shankar.
Yeah.
Good morning,
Mamta, yeah, Mamta, I could not see you. Audio.
Am
Your
I
video.
audible? I'm
Yeah, audible. Not no video. Yeah. Now, yes. Yes, I can see now. Yes. Yes, I can see you now. Okay,
Yeah.
Mamta. Nice to see you. For
Same
since a
here.
long time ago in the conference.
Yeah.
After post graduation. Yes.
Right,
Nice
right.
to nice to see you.
Namaste, ma'am.
Yeah.
Namaste and a very
Namaste.
good morning to all the delegates present here today. A warm welcome to all the delegates for the second day of the Isoparb, the 36th Isoparb National Conference, organized by IMS and Some Hospital, the Bhubaneswar chapter of Isoparb. After yesterday's enlightening and extremely beneficial workshop, we move on to the second day of our third day academic extravaganza with the same zest. Okay, we will begin today with our symposium session. Okay, I would like to invite the respected chairpersons for the symposium, Dr. S.J. Patel, Dr. Anjana Jha, and Dr. Sasmita Das, ma'am.
Yes.
Yes.
Welcome, sir.
Yes.
Yes, I'm here.
Am I audible?
Yes, sir, you're audible, sir.
Okay. Yes. Certain.
Shall I start sharing my screen?
Ma'am, just a minute, ma'am. I'll just
Okay.
introduce the chairpersons. Dr. Shankar Jaikisan Patel, he's a senior consultant obstetrician in Jagyasini Hospital, Jharsuguda, Odisha. He is a consultant in different capacity at Nehru Shatabdi Central Hospitals. He has an experience in the field of ultrasonography, infertility, colposcopy, and laparoscopic surgeries. Our next chairperson is Dr. Anjana Jha. She's a Chief Medical Officer at Gandhinagar Hospital, Jharkhand, and she has won the CSR Award for the year 2012 in CCL. Her special interests are in high-risk pregnancy. She has been a speaker and a panelist in various state level and national level conferences. Our third chairperson is Dr. Sasmita Das, who is a professor and in the Department of Obstetrics and Gynecology, IMS in some hospital. She has 18 years of clinical and teaching experience. She has several publications in national and international journals for her credit. Her areas of interest are high-risk pregnancy and fetal medicine. We welcome you, ma'am. We welcome all the chairpersons. So you can start the session, sir. I request Dr. S.G. Patel to kindly introduce our first speaker for today, Dr. Mamata Datta Rath.
Yes, ma'am. Before going for introduction of Mamata, ମୁଁ ସମସ୍ତଙ୍କୁ ମୋର ହୃଦୟରୁ ନମସ୍କାର କରୁଛି. A very warm good morning to all my esteemed teachers, senior friends, fellow delegates. I feel extremely privileged and honored to chair today's first academic session, a prestigious 36 Isoparb National Virtual Conference 2021. So the world is ever changing with this COM. The never-ending challenges to preventive, investigative, diagnostic, and curative domain of gynecology and pediatrics. In this context, today's vibrant deliberation and significant conclusions certainly create many milestones ahead to reach our goal in achieving a state of comprehensive patient care in the realm of gynecology and pediatrics. Our unending path in pursuits of research-oriented work, culminating in technical development to attain easier approach to our day-to-day problem that we face in our specialty in wide open. So the International Federation of Gynecology and Obstetrics developed a classification system, PALM-COIN, to help categorize both structural and non-structural causes of abnormal uterine bleeding. When diagnosing heavy menstrual bleeding, these potential underlying causes should be investigated. Heavy menstrual bleeding is a symptom which may be caused by several underlying medical conditions. In clinical practice, there are several treatments that are used despite not being specially approved for heavy menstrual bleeding. The following section is intended to give an overview of what is the clinical practice. I heartily thank organizer for giving me the opportunity to be a part of this august gathering of brilliant professionals, academicians, and aspiring alumni. Let us resolve and commit to utilize our knowledge, best skill, techniques for the benefit of the patient in these fields. So, though Mamata Rath needs no introductions, as a customary, it is my pride privilege to introduce her. So she is a chief consultant in the Department of Obstetrics and Gynecology in Tata Main Hospital, Jamshedpur. And it is fortunate that she has won the East Zone quiz held in Calcutta in the year 1997. So also, same year, she won the national quiz held in the AICOG Pune. So she had many awards for presenting long papers, and that in all steel medical officers conference in the Jamshedpur in the year 2002. She is also have this credit for delivering the Kamini Rao oration in the All India Congress of Obstetrics and Gynecology held in Odisha in Bhubaneswar in the year 2002. And she is also fortunate to own the award of Dr. C.S. Don Award for the best paper in the senior category in the AICOG 2010 at Guwahati. To her credit, she has many publications. For time constraint, I am not reading all this, but she has many publications in the national, international journals. So also, she had different publications in the index journals and British Medical Journal. And she had also added some chapters in different books. And her special interest is laparoscopy. And last but not least, she is my classmate. We have done post-graduation both in Burla in the year 1991 to 94. I'm fortunate enough to have her classmates. So this is her brief introductions. There is a long list of publications in her CV, but due to time constraint.
Sorry to interrupt, sir. Let us move on to Mamta Dutt ma'am's presentation. Sorry, sir. We are running short of time.
Yeah. That will be from that side, I think.
Yes. Now
okay.
I request Dr. Mamta Dutt to kindly share her screen and start with the presentation. Ma'am, can we have you?
Yeah, thank you
so much,
for the kind introduction. But if you stop sharing your screen, I can share my screen. You are still sharing your screen.
Yeah, I am. Yeah, from my side.
And I think the organizer's side.
Organizer, yes. I have not shared the screen. Yes.
Is my screen visible?
Yeah, yes, Mamta.
Yeah. Good morning, everyone. Thank you, Shankar, for a very nice introduction.
It's my pleasure.
Good morning, chairpersons and all the audience. I thank the organizers for having given me this wonderful opportunity of being a part of the 36th annual Isoparb National Conference. I would be speaking today on palm coin classification and its clinical significance.
Sorry to interrupt you, ma'am. It's for the kind information of everyone. We have an autocorrect system. Please stick to time, please. Thank you so much, ma'am. You can start your presentation.
Okay. So over the course of next 12 minutes, I would be talking about what is palm coin classification, how the AUB classification systems developed, and the clinical significance of the palm coin classification or the AUB systems. So what is palm coin? It is a system of classification of abnormal uterine bleeding in the non-gravid reproductive age women. So the palm coin system was developed by FIGO. It recommended two systems, AUB system 1, which defined the terminology and the definition of AUB, and AUB system 2, that is the palm coin system, which classified the causes of abnormal uterine bleeding. So why was palm coin system developed? After all, we were treating these abnormal uterine bleeding for a long time. It is important to note that about 1/3 of the population in the reproductive age group women have suffered from AUB, causing severe disruption of work productivity and quality of life. May also be related to maternal morbidity and mortality due to anemia related to AUB. And it was felt that there is absence of a consensus system for the classification of the causes or the potential causes of abnormal uterine bleeding. So a need was felt to develop a system that was consistent, universally acceptable, and could be used by clinicians, investigators, or even patients to facilitate communication, clinical care, and research. And palm coin was proposed as a tool to meet all these requirements. So how did these AUB classification systems evolve? So in 2015, FIGO constituted the Menstrual Disorders Working Group, which consisted of experts from all related fields with the sole aim of tackling the issues of abnormal uterine bleeding in a systematic fashion. In 2007, the AUB System 1 was first published simultaneously in Fertility, Sterility, and Human Reproduction journals, which recommended a substantial revision of the existing terminologies and definitions. It redefined the normal parameters of menstrual bleeding, and certain terms were abolished with which we were very familiar with when we were doing our training. That is menorrhagia, metrorrhagia, and dysfunctional uterine bleeding were no longer suggested to be used. In 2011, the landmark publication in the flagship journal of FIGO, the IJGO by Munro et al., described the AUB system 2, that is the palm coin system. And this palm coin system consists of, the palm part consists of, is the acronym for polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia, which basically denotes the structural entities which can be evaluated and diagnosed by imaging and or biopsy. The COIN acronym stands for coagulopathy, ovulation dysfunction, endometrial, iatrogenic, and not yet classified. Basically, the non-structural entities, especially the underlying medical disturbances that could result in abnormal bleeding. Also came the concept of chronic AUB and acute AUB. Chronic AUB was bleeding from the uterine corpus that is abnormal in duration, volume, frequency, and regularity, and must have been present for the majority of the preceding 6 months. Acute AUB was defined as an episode of heavy bleeding that was of sufficient quantity to require immediate intervention to minimize or prevent further blood loss. Acute AUB may also occur in the in the setting of an existing chronic AUB. The most recent revision of the FIGO systems is the 2018 revision in the IJGO journal, and it revised some of the conditions that were previously described in 2011. To bring your attention to the first point is that the N part of the COIN acronym was described as not yet classified in 2011, while in 2018 it became not otherwise classified. The other modifications in 2018, intermenstrual bleeding was added. There was a practical definition for irregular menstrual bleeding, which included the 75th percentile, thus excluding the outliers of the cycle length. And the definition of heavy menstrual bleeding was proposed by NICE, and this was adopted, which was excessive menstrual blood loss, which interfered with the woman's physical, social, emotional, or the material quality of life. And it also suggested that the normal range of cycle is dependent on the age of the woman. So the revision of the symptoms 2018 revisions, to summarize these changes, amenorrhea now became a part of the frequency. So the normal menstrual pattern or menstrual cycle can be defined as per the frequency, duration, regularity, or the flow volume. A frequency, it was said to be infrequent if occurring at more than 38 days interval. Normal cycle, 24 to 38 days cycle. Frequent if it was less than 24 days cycle. The duration has only two categories: normal less than 8 days, prolonged more than 8 days. Regularity has been refined. It is either irregular, normal variation is from 7 to 9 days, and irregular if the variation of the shortest to longest cycle is more than 8 to 10 days. The flow volume is patient determined. It may be light, normal, or heavy. Also introduced was the term intermenstrual bleeding in the 2018 system, and it may be defined as being random or cyclic, and if cyclic, whether early cycle, mid-cycle, or late cycle. The other inclusion was the unscheduled bleeding when on gonadal steroids, and it was denoted as whether it was present or absent. So coming to the palm part of the AUB system 2, in 2011, the polyps was scored as absent or present. Adenomyosis was also similarly scored absent or present. Leiomyoma was scored as primary level as present or absent. Secondary level, whether it was submucosal, that is leiomyoma SF, or others, that is leiomyoma O. And tertiary level described the location and the size. And the M referred to malignancy and hyperplasia, which was later characterized by the staging system proposed by WHO and NICE guidelines. However, in 2018, the AUB-A and AUB-L had refined sonographic diagnostic criteria and definite parameters for differentiation. The Cohen part, the AUB-C coagulopathy no longer includes the AUB associated with pharmacological agents that impair blood coagulation, which are now included in AUB-1. AUB-O no longer includes the ovulatory disorders associated with drugs which are known or suspected to interfere with ovulation, such as some of the dopamine agonists, the antipsychotic agents. And as I have already mentioned, AUB-N is now changed to not otherwise classified. And this would include all those conditions which are ill-defined till date, and all those potential causes that may be related to abnormal uterine bleeding. And a potential new cause of AUB has been discussed in this section, that is the isthmocele following a lower uterine segment cesarean section. So coming to AUB-A, the MUSA criteria, that is morphologic ultrasonographic uterus sonographic assessment group, have given 8 criteria based on the transvaginal sonography findings. Type A, asymmetrical myometrial thickening; B, myometrial cysts; C, hyperechoic islands; D, fan-shaped shadowing; E, echogenic subendometrial lines and buds; F, translesional vascularity; G, irregular junctional zone; and H, the interrupted junctional zone. Presence of 2 or more of these criteria is highly associated with the diagnosis of adenomyosis. Now coming to the leiomyoma, defined as submucous or other leioma L, SM, or LO. And here the type 3 is now a part of submucous leiomyoma. Type 0 denotes, can refer to the diagram on the left-hand side. Type 0, pedunculated intracavitary. 1, less than 50% intramural, which is the submucous. Type 2, submucous, more than 50% intramural. Type 3, which is submucous, the myoma is 100% intramural, but connects with the endometrium. Type 4 is totally intramural, no connection with endometrium or serosa. Type 5, subserous, more than 50% intramural. 6, subserous, less than 50% intramural. 7, subserous pedunculated. And others are type 8 includes the other fibroids, such as the broad ligament, the parasitic, or the cervical fibroids. Another type is the hybrid type, is a fibroid which contracts.
Sorry to interrupt you, ma'am. Ma'am, you have 1 more minute left, ma'am. Kindly wind up soon.
No, but I think I was given 15 minutes.
Ma'am, it's 12 minutes.
And because there was a lot of interruption in between, I started late.
Okay, ma'am, carry on for 15 minutes. Then after that, it will be a auto-cut system, ma'am. So kindly wind up soon.
So the hybrid system are those serosas, the submucous, the 2 numbers are listed separately and refers to the relationship with the endometrium, while the first one and the second refers to the relationship with the serosa. This type 2 to 5 in the diagram is a hybrid system. And type 0 and 1 are and 6 and 7 are distinguished by comparing the stalk diameter. Type 2 and 3 by the lowest filling pressure that allows visualization of the cavity. And I think because of actually my talk was timed and I was well within the time, but anyway, if your system is going to auto cut according to your system, I'll just wind up. So there are certain recommendations. We must state the location, the volume of the largest myoma, and if possible, describe the FIGO classification system. The AUB system, the FIGO system actually prompts the clinician to use the notation system. An example would be if a person has endometrial hyperplasia and ovulation dysfunction, then in the palm point notation, M1 and O1, in the complete notation, P0, A0, L0, M1, C0, O1, E0, I0, N0, and may be abbreviated at M as AOB M0. These are certain other examples where we are using the notation system for multiple abnormalities that may be contributing to AUB. The AUB diagnostic matrix is also proposed by the FIGO classification systems to be used for categorizing a patient with AUB. On the vertical axis, it has the palm coin, and on the horizontal axis, whether it is present, whether it is not present, or question mark, that is whether it has been evaluated or not evaluated. So these are the certain examples where we can use the palm coin system. In this, in the first figure on the left-hand side, system 1, where we look at the symptoms, cycle length, regularity, duration, volume, presence or absence of intermenstrual bleeding. System 2, where we give the cause with the help of the diagnostic matrix. Here, the woman has a long duration and heavy menstrual bleeding, and she has leiomyoma SM. So in the Y column, the submucosal leiomyoma has been checked. So these are certain other examples. And just to bring your attention to the right-hand side, right-hand diagram here, the diagnosis is AUB A and C, where there is coagulopathy, which is tested by the screened by the symptoms first, and then tested by the von Willebrand factors, ristocetin, APTT, PT, and PT, and factor VIII estimations. And A stands for adenomyosis. So this is a flow diagram based on the palm coin system, how to proceed chronic AUB.
Sorry, ma'am. Sorry to interrupt. There's an AutoCAD system, and this slides has stopped, ma'am. Stop sharing. We request the next speaker, ma'am. Okay, our next talk for today is Management of Endometriosis, Current Surgical Trends by Dr. Ashish Kale. I request Dr. Anjana Jha to kindly introduce Dr. Ashish Kale.
Her mic is mute.
Sir, you're audible, sir.
Okay.
Yeah. Now, good morning, everyone. I'm very happy. I have given the pleasant task of introducing Dr. Ashish Kale. He is MD, DNB, MNAMS, Diploma in Endopelvic Surgery from Germany, MICOG India, FICS, FICMCH. He is Director, Asa Kiran Hospital, Pune and Baner. He is also Director, Asa IVF Center, Pune and Baner. Director, Arunachal Test Tube Baby Center. He is founder member and librarian Maharashtra chapter IAG 2019 to 2021. He is executive member National IAG 2019 to 21. Executive member of Maharashtra chapter ISAR MISAR 2018 to 21. Executive member of National ISAR 2018 to 22. Published many papers, posters, research articles at many national and international journals. He has presented many papers, posters at many national and international conferences. Now I request Dr. Ashish Kale for his talk, please.
Thank you, madam, for those kind words. At the outset, I'm thankful to organizing team. I'm audible?
Yes.
Yeah, my screen is shared, I think.
Yeah. Screen is shared.
Yeah. Thank you, ma'am. And thank you, Isoparb team, for inviting me. Today, I'll be talking about the surgical trends in endometriosis. All of us knows the endometriosis is the disease which comes from the adolescent age group till the perimenopausal age group. So, but when we're talking about the surgical trend in the endometriosis, we should be talking about in which patient we should operate and in which patient we should not operate. And what are the strategies when you're talking about the operative in endometriosis? So I'll coming down to the main part of the endometriosis where we wanted to operate. Usually the patient, even if it is adolescent endometriosis or maybe in infertility patients, those are the patients where they come up with the pain, or maybe there is a complications of the endometriosis, or there is a spontaneous rupture. In those patients, we definitely wanted to do the operative. But endometriosis and infertility is such a condition which goes hand in hand. In up to the 1/3 of the population of the infertile patients, they come up with the infertility and having the endometriosis in themselves. 20 to 40% of this woman undergoes the ART procedure having the endometriosis. So endometriosis is not that uncommon. It is when the infertility patient coming down to you, they may have a endometriosis in them, but that particular patient has to undergone a knife, or whether they wanted to go for a ART procedure first, that we should be talking about. Why we need to do the surgery in those patients? Because we know in endometriosis there is maybe adhesions and maybe a tubal blockage. So definitely we wanted to know what is the staging of the endometriosis. We do put a laparoscope, and we do what you call as reversed American Fertility Society scoring, and we come to know what are the anatomical distortions, what is the chronic pelvic pain. If at all there is a dyspareunia, we know there are the adhesions, then we know there is a DIE which plays the role. The poor ovarian reserve is another worry for infertility specialists like us, to know whether we should operate or we should not operate, because in those patients AFC and AMH levels are on a lesser side. So even if we wanted to operate, we don't want to operate in such a patients where they have a low AMH. Again, we are going to operate them and making the AMH a little bit on a lower side. We know the gametes are going to affected by the release of the cytokines, and it also implantation is going to hamper, because these are the patients is not only be associated with endometriosis, they have the adenomyosis. And for all of us knowing that adenomyosis patients, in order to have the conception, is in a little bit lesser side. Coming down to the when the endometriosis patient coming down to us for the infertility, what we should be considered prior to the operative, and what is the recent trends. We must consider her age, we must consider her ovarian reserve. If the ovarian reserve is on a normal range or on a higher side, definitely a cystectomy is a role when she coming down to us for a pain. But if the AMH and AFC is low, we should not be doing a cystectomy in those patients. It is better to go for ovulation induction or ART procedure prior to the operatives. Medical risk with the surgery. If you going to give a newer drug like a dinazole is not been used, now a Dynogest is been used. A Dynogest or maybe a JENA analog can be used in those patients, but then the surgical part of it becomes a little bit difficult. It depends upon the surgeon's skill. I know everyone is skilled enough, but when the endoscopic surgeon they operate a too radical rather than a conservative approach. Overall, as expected success rate has to be talked to the patient, what actually you are going to do in the endometriotic patients, what is the principles of the operatives has to be talked to the patient. When you do a laparoscopy, it's better when the patient is at a younger age, less than 37 years. The shorter duration of infertility, if she's having an infertility for less than 4 years, it is better to do a laparoscopy, because in those patients, if we address the endometriosis in a lesser grade, a grade 1 or grade 2 endometriosis, where we do a total perinatectomy, where the chances of spontaneous conception rate is on a higher side. If the patient is having a normal male factors, normal uterus, it is definitely going to give a more results as far as the ART is considered. And where we are documented the normal ovulation, a COH IUI or maybe ART procedures can play a role. The basic principles of any surgery, we know the basicest thing is that we should counsel the patient. We should counsel the patient about what is the take home of the surgery. What is the whether the pain threshold is going to get reduced. What is the recurrence rate? Because the endometriosis is not the disease that when you are doing the total laparoscopic surgeries and going to read out of the disease. It's not like that. It is there has to have a recurrence. So we must talk to the patient about the recurrence of the endometriosis. Secondly, we have to give a counseling of the fact that if the AMH is less, it is better not to do the operative. If the AMH is good, we can do the operative and AMH can regain back after 3 months, and then we can do a counseling or maybe a ART procedure. Diagnostic laparoscopy for endometriosis not plays the role. Even if it is a diagnostic, it has to have the operative. You have to take the biopsy. You have to do the total peritonectomy when there is a peritoneal implants. The infertility medical treatment is no. It goes to hand in hand when you're talking about the infertility patients. Conservative surgery is not been recommended because only a cystectomy or a cyst aspiration for that matter is not been recommended because the chances of recurrence is high. You must be doing total cystectomy in the endometriotic patients. Basic conservative treatments, as I talked to you, is not nowadays. Fulguration is not the rule. We do a excision. Sulfango ovariolysis, there is adhesions. Definitely, we are going to do that, and ovaries are always been preserved. These are the videos where we definitely know in which patients definitely we are going to do the surgery. If these are the adhesions, even if we go for ART procedures, you can see the bowel is going to get adherent, and in those patients it is definitely do adhesiolysis, because the ovaries will be more accessible and home pickup. We all of knows that the uterus is retroverted or because of the adhesions. The rectosigmoid junctions has to be freed because the correction of the anatomy plays the role. And when we are doing such a procedures, always maintain the normal axis of the uterus, because the embryo transfer in later age will be much more easier. If you see down videos, there is a rectal endometrial adhesions. It is always better to go from pararectal areas. I will be showing it in a while. And these are the certain principles where you just do adhesiolysis, and the ovarian fossa is been released, and then the normal anatomy of the ovaries and the tubes are preserved. So these are the certain things where all the anatomy aspect of the principles that has to be taken into account. Ovarian endometrioma, all of us knows there is a ISHRE guidelines that's more than 4 centimeter ovarian cystectomy. Ovarian reconstruction, depending upon how much is the ovarian cyst. If the ovarian cyst is a bigger, then ovarian reconstruction is required. You can do suturing, or you can just do approximation of the walls. The plain relief is a pre-sacral neurectomy. Nowadays, none of us are doing it because it doesn't show any impact as far as the pre-sacral neurectomy is considered, and the pain relief. Definitely a bowel preparation is required, and the hydrodissection, or maybe you can go from the pararectal spaces, and then you can adhere, and bowel can be taken into account. Surgical treatment based upon the non-visualized endometriosis. What I mean by it, when there is endometriosis, you just do a peritoneal excisions. You can see there are the deeply seated endometrial implants, and that can be taken out. The DIE is rectovaginal pouch endometriosis. The treating in other areas has to take into account. The diagnosis and the treatment, the laparoscopic surgery is a gold standard when you are doing just not to see, just not to just fulgurate. It is better to do a peritoneal biopsy of these patients. Then coming down to the minimal endometriosis, removing and destroying the implants, which will give us more success rate. If you are having a grade 1 endometriosis, it's better to do the fulguration or maybe a biopsy of the implants. Where there are the reports where in a grade 1 and grade 2 endometriosis, spontaneous pregnancy rates are on higher side after the laparoscopy. And if in a grade 3 and grade 4 endometriosis where there is a rectal nodule, if you do a DIE surgery, the chances of spontaneous conception is on a higher side. And even if it is not like that, after 1 month, you can definitely go for ART treatment. These are the comparison when you are just doing the surgery versus the surgery with the operative management. It's always favors that when you do just not a diagnostic laparoscopy, it has to have goes with the operative laparoscopy, has a proven pregnancy rates. Indications for the surgery is the symptoms refractory to the medical line of treatment. Mind well, where possible, you start with the medical line of treatment and then jump over to the surgical line of treatment. Those who needs immediate surgery is like there is a uterosacral environments where there is a pain, or whether there is a bowel stenosis or rectovaginal endometriosis, where there is a symptomatic patients or the endometrium is a rupture. In those patients, definitely immediate surgery is required. Value for laparoscopic surgery is to there are randomized control trial and in Italian trial, and there are number of RCTs which will tell you that whenever there is endometriosis, medical line of treatment is the first choice. But if she is not responding to the medical line of treatment, better to do a laparoscopic surgery. And first laparoscopic surgery is always the last laparoscopic surgery for those patients. So make a complete job of that patients. This is the cumulative pregnancy rates when after 12 months after the laparoscopy with the endometriosis. If you see the spontaneous pregnancy rate after the pregnancy after the laparoscopy is increased after 3 months, but it remains the same. So whenever you wanted to do the laparoscopy, after the complete job of the laparoscopy, you do a 3 months of a follow-up of the patient, because the spontaneous pregnancy rates after the 3 months is higher, but not more than that. You can wait. Then you need to resort for the IUI or for IVF for those patients. These are the RCOJ's recommendations, where in the mild and about minimal endometriosis, undergo laparoscopy should be offered. Is a surgical ablation or a resection of the endometrial implants, what I talked about, should be taken into account. The ISHRE guidelines, the endometrioma, if it is more than 4 centimeter, definitely it has to be excised. Endometrioma less than that doesn't require as such the surgical line of treatment. You can go with the medical line of treatment. The FIGO also has the same guidelines. If the endometrioma is more than 4 centimeter, definitely excision and the biopsy is required, because there are certain cases to rule out the rare evidence of the malignancies. So these are the certain videos of the endometrioma. I will not go into the details. Basically, when you are doing a cystectomy, be close to the cyst wall, because whenever you are close to the cyst wall, the normal and ask your pathologist to see whether the normal ovarian cortex has been taken out with the cyst itself or not. Because if you are close to the cyst wall, and if at the cortex of the ovary, usually the cyst wall is adherent. So make sure that there is a pinpoint coagulation if there is a bleeding, and if there is a major defect in the capsule, it is better to suture it up, because if you leave the capsule like that, it again causes into adhesions and may ovaries. There can be a different way.
Sorry to interrupt, sir.
Yeah.
We're running short of time, sir.
Yes. I am just going. I think I will just show a certain of AMS, AFC. I talked about capsule excisions. If there is some video, I can like to. So I'll like to talk about the ureterolysis, and I will not go into the details of it, DIE and the surgical. What the take-home message of the recent trend is like that whenever you are wanted to do the surgery for the endoscopic surgery for the endometriosis, the complete job. The first is a medical line of treatment, categorize the patient. If the patient is having the symptoms, better to deal with the symptoms medically. If not responding medically, do the laparoscopy. Diagnostic laparoscopy doesn't play a role. It is always operative laparoscopy. Wait for 3 months, even a grade 1 and grade 2. If it is a grade 4 endometriosis, bilateral endometrioma, do ART procedures first and then do a laparoscopy. That is called as a sandwich therapy. It is always better to give certain points. When you're doing a laparoscopy, there is a ureteric, there is hydroureter, so it is better to do a complete job. You can do the stenting of the ureters, you can do the reanostomosis, but mind well, whenever you are doing it, it requires a multidisciplinary approach. You need to understand the planes, going from the virgin plane to the adherent plane is the take home when you're talking about the advanced laparoscopy in endometriosis. Identify the structures, goes into the spaces, goes retroperitoneal. One should be knowing about the retroperitoneal anatomy very well prior attempting the endometriotic surgery. Going from the pararectal spaces, then addressing the rectal nodule is an easier approach rather than directly going into the rectal nodule. Similarly, uterine ureters has to be identified on the lateral pelvic wall. Clamp the temporary clamping of the uterine artery reduces the bleeding, because this is usually a neovascularization is going to happen. So if you have a hydroureters, pre-diagnose it and then do a ureteric reimplantation in those patients, because these are the patients where the first surgery has to be very meticulous, because repeated surgery is causing a distortion of the anatomy, and which will not have a helpful for the another surgeons to go in and finding it out difficult while operating. So the first is a do a ureterolysis, go into the avascular plane, do the proper dissections, and then address the disease. I think because of the short of the time, I'm really thankful to all of you.
Thank you so much, sir. We'll be moving on to our next session. Our next talk is on adolescent PCOS by Dr. Gopa Chowdhury. I request Dr. Sasmita Das ma'am to kindly introduce our speaker.
Good morning to one and all. Adolescent PCOS is in rising trend, and it is a real problem with incidence and diagnosis. So today I would like to invite Dr. Gopa Chowdhury to speak about this burning issue, and she is a retired associate professor of obstetric and gynecology. She is MD FICOG from Ranchi. She is the editorial board member of Innovative Publications, Journal of Women's Health Care and Issues. She has received many awards. She is the author of Fundamentals of clinical risk management in obstetrics. She has many national, international, and awards, publications and awards to her repute. I would like to welcome Madam. Please deliver your speech. Hello.
Yes, ma'am. Dr. Gopa Chaudhary, ma'am, are you there?
Hello.
Yes, madam, you are audible. Please share your screen.
Yeah. Hello. It is visible?
Ma'am, your screen is not visible, ma'am. A gentle reminder to all the speakers, kindly wind up by 12 minutes because we have an autocut system.
Okay.
Yes,
okay. Good morning to everyone. And thank you, Shasmita, for telling such a good praise of mine. Thank you. Now, I am Gopa Chaudhary from Ranchi, as you introduced. I'm now starting my video and the topic, adolescent pregnancy. Now I will run the PPT. Hello.
Yes, ma'am, you're audible, ma'am. And also your slides are visible.
Yeah, the adolescent pregnancy, as we know, that it is a WHO, that adolescent. The adolescent group, as we know, it is between 10 to 19 years, as WHO defines, and it is the period of transition from childhood to adult sexual, physiological, and psychological maturation and development. And that significant metabolic and endocrinological changes from the background of this transformation. This is a very important period. The polycystic ovarian disease, as we all know nowadays, is very common in the young girls. It is about 36%. And it is a heterogeneous syndrome of unknown etiology. There is vast endocrine and metabolic disorder. It also affects the reproductive age group 5 to 7%. Now, it was first detected by Mr. Stein and Michael Leventhal in 1935. And in our time, that is in the past, it was known as Stein-Leventhal syndrome. We should know about the predisposing factors, the prenatal exposure to androgen, daughters of PCOS mother, low birth weight, premature puberty, type 1 diabetes, obesity, and insulin resistance are some predisposing factors. Weight gain, obesity during adolescence carries a higher risk of early puberty, estrogen-dependent diseases in the later life, including PCOS and breast cancer. BMI correlates with total testosterone, SHBG, and free testosterone. Now, the etiology. The etiology is unknown. It is multigenic in origin. It may be hereditary or genetic. The pathophysiology of polycystic ovarian disease is here. I have shown in the chart. There is primary endocrine, it is a primary endocrine condition, and secondarily, it is the aberration of HPO axis. Due to the abnormality in the regulatory mechanism, gonadotropin axis, HPO axis, there is elevation of GnRH that leads to LH and LH and FSH secretion distortion. And it is sometimes we get LH FSH ratio 3:1. There is simultaneous involvement of adrenocorticotropic hormone and somatotropic hormone. Due to the involvement of adrenocorticotropic hormone, the AAS, that is the adrenal androgens, becomes high. And due to aberration in the somatotropic hormone, there is increased growth hormone, increased physiological insulin resistance, and there is more hyperinsulinemia, which leads obesity and hyperandrogenism. That means the result is increased androgen. And this hyperandrogenism produces so severe features. There is disturbed LHS FSH. There is rise in growth hormone and hyperinsulinemia associated with decreased level of SHBG, IGBP1, leading to increased androgen. The diagnostic parameters are biochemical markers. They are the elevated free testosterone and biochemical hyperandrogenism and others. The elevated free testosterone is there, but DHEAS or 17-OHP are high. Now, total testosterone, dihydroepiandrosterone sulfate, and DHEAS, they assay the adrenal androgen, and free androgen FAI index is high, or 17-OHP is done to assay 21-hydroxylase function of adrenal gland. SHBG is decreased, LH-SPH ratio may be normal, may be distorted, serum prolactin may be raised. AMH is one of the important parameter for PCOS. Ultra 3D ultrasonography is done. Now, other tests which we should do are thyroid function test. The AMH is considered the hallmark of the thyroid function test because in hypothyroidism, there is distorted hormone secretion and the patient becomes anovulatory and there is menstrual irregularity. AMH is considered hallmark of PCOS because high follicle number 5.0 ng per m, it may be up to this. 3D ultrasonography is shows polycystic ovarian morphology. Polycystic ovarian morphology in adolescents, clinical and biochemical evidences of hyperandrogenism are essential for diagnosis of PCOS. Other features defined by Rotterdam group may be normal in non-PCO adolescent. The treatment plan in adolescents. It is very important part because every one of us are dealing with the adolescent PCOS. The objective of treatment is treatment of oligomenorrhea, amenorrhea, hirsutism, acne, and reducing the consequences of insulin resistance and glucose tolerance. Treatment plan in adolescents due to uncertain etiology and pathophysiology, a definite standard of treatment protocol cannot be formulated. So it can differ from patient to patient, from adolescent girls to girl to girl. The management plan is individual. That means the management plan is individualized. It is different in different patient. The protocol of management. First is weight management. We do the weight management because weight is the most important thing. It is directly related to. The weight is directly related to the secretion of androgens and oral contraceptive pills, anti-androgens, and cosmetic treatment. The weight management is done by reducing the weight, changing the lifestyle, because nowadays this lifestyle change in the lifestyle, westernized lifestyle, mainly say there is mainly the babies, that the adolescent girls are overweight. So change of lifestyle, importance is given to exercise, do the exercise properly, importance is given to the exercise, and a diet chart is made. Exercise is important because that burns the body fat. In PCOS girls, it is very important to have the habit to early diet management properly and others. Other treatments that include is their drugs and anti-androgens, the drugs that for ovulatory dysfunction and also for amenorrhea and anovulation we give. Generally we give EE, ethinyl estradiol, with estrogen or with ethinyl estradiol with progesterone or with dydrogesterone. Now the second group of drug is anti-androgens, that is the cyperterone acetate with or without EE. And other drugs that we consider are dexamethasone, that is the prednisolone, but they are given in the patient in whom the adrenal androgen is very high. And then cosmetic surgery is also done. Drugs we give, then we give the cosmetic surgery, cosmetic treatment, that is the epilation, etc. That is the epilation, etc. Now we can say that adolescent PCOS is very hard and very tough to deal with, as I have said, that the different patients they have response in different group of treatments. One is for insulin resistance, so we should give the metformin in the dose of 1500 divided dosage, 500 thrice daily, which will decrease the insulin and level in the body, and that will improve the condition. It is often perimenopausal in onset, but to summarize, it is said that it is often perimenopausal in onset. There are many similarities between physiological changes of puberty and pathological. Hello?
Yes, ma'am. Sorry to interrupt, ma'am. We're running short of time.
Okay, thank you. I am concluding. PCOS is often perimenarchal in onset. There are many similarities between physiological changes of puberty and pathological features of PCOS. The reversible physiological changes during puberty may sometimes persist and behave abnormally to contribute to the genesis of pathological changes observed in women affected with PCOS. Long-term metabolic derangements in PCOS may invite life-threatening complications with morbidity and mortality risk. Data shows a significant increased rate of type 2 diabetes mellitus, dyslipidemia, and endometrial cancer have twofold increase in the prevalence of metabolic disorders. During adolescence, there is no consensus as whether to use either NIH or AES criteria of diagnosis of PCOS. The diagnosis here is based on hyperandrogenism associated with menstrual cycles persistently longer than 45 days. Thank you for hearing me and for inviting me in the conference. Thank you very much.
Thank you, madam.
It is within the time?
Yes, ma'am.
Yes,
Thank you, ma'am.
Okay, thank you.
Moving on to our next session, we are going to start with the Symposium 2. It's my honor to invite our chairpersons for the Symposium 2, Dr. Amita Tripathi.
Yes, I'm here. Hello.
Yes, ma'am.
I'm audible. Let's start with the Symposium 2, that is on infertility. And the first talk is on semen analysis and overview. And the speaker is Dr. Narhari Agasti. He is Professor KIMS at Bhubaneswar. Please show the CV. Hello.
Yes, ma'am. We're sharing this.
Yeah.
Yes.
So we have three topics. First is on semen analysis. Second is on ovarian reserve, comparing AFC and infertility. And third is on the surrogacy bill. And please show the CV. And our first topic is semen analysis and overview. And our speaker is Dr. Narhari Agasti. He is professor at KIMS, Bhubaneswar. He is member of FOXI, Isoparb, AOGO, and to his credit, he has many publications. His special hello.
Yes, ma'am, you're audible, ma'am.
His special interests are endoscopy, infertility, and high-risk obstetrics. Dr. Narhari, with this, please, I request you to continue with your talk. Hello? Hello? Dr. Narhari is there? Hello?
Yes, ma'am. Dr. Narahari Agasti. Sir, are you present? Hello, sir.
Dr. Narhari?
Kindly unmute, sir.
He's there?
Yes, ma'am, I'm there. Am I audible?
Yes, yes, sir. Yes.
Just I want to share my screen because the host has muted me. Yeah, yeah.
Okay, sir. Okay, sir.
Yeah. Good morning, ma'am. Thank you for nice words. It is my pleasure to be here on this virtual meeting after the COVID and another second tide is coming. Pray God that everybody should be safe and thankful to the organizing committee, especially my elder brother Tapanbhai, to giving this opportunity to share my few experiences regarding the semen analysis. Semen analysis in overview means, because if you go for infertility is defined in inability to conceive within 1 year of a regular unprotected sexual intercourse for 1 year at least, and 4 to 5 times in a week. And in any infertility cases, male factor, female factor, and combined factor. And if you go for combined, it's 20%, and individually 20 to 30% male factor is responsible. Greeting from land of Lord Jagannath. So this whole cause 20%. Semen analysis means it measures the amount of semen in male producers, because the irony of male factor in fertility is, if you do a seminogram about 24 hours, the seminal count varies from day to day. So that's the reason why the research has come to a fixed criteria on 2010. I'll come to the next slide. And with the first step to rule out any male factor or infertility issue. Because in case of infertile couple, the male factor only that you have to go for a semen analysis and you see it falls under criteria, normal criteria or not. Because over the years, what happens now, the great concern is the Y chromosome microdeletion, which is coming in a big way, and we don't know at what end we are there. And the problem with the semen or sperm affects more than 1/3 of couples who are unable to have children. Coming an overview, I'm not going in the sperm function test. I'm just discuss about the seminal analysis. Seminal analysis, you have to take sperm count, sperm morphology, and sperm motility. In the sperm count, normal sperm count or low sperm, normal morphology, because most of the embryo which is going to form, it depends on how much the sperm is fertile and what is the morphology. Because if the morphology is bad, the DNA fragmentation index is high, so there is less chance of good embryo or there is recurrent implantation failure. Next is motility. And something about the human sperm, there is a head, there is a midpiece, there is tail, because it is structurally important. And if there is any structural abnormality in these structures, so then there occurs a fertility issue. The semen analysis are mainly carried out to determine whether a man has a reproductive problem that is causing infertility. It is a single test that will provide information whether the parent father can be, or it also tells about the patterns of male ducts, because when there is a azoospermia, it may be obstructive or it may be a testicular atrophy. So that will determine. Semen analysis is from day to day, it varies. And also semen analysis also done to test the effectiveness of vasectomy, which is usually done 6 weeks after vasectomy. So the sample collection is the initial crucial step for any semen analysis, because It should be given a clear written instruction concerning the collection, handling, transport of the semen sample. The semen sample should be collected after minimum 48 hours abstinence, 2 to 3 days, but not more than 7 days. But more of the oxidation, oxidative stress occurs. And ejaculate should be near to the lavatory, and it should be given to the lavatory not more than 30 to 40 minutes. And usually we do either by masturbation or by coitus interruptus or assisted ejaculation in case of paraplegic patients. Once after collecting the semen sample of the patient, the receiving time is noted down. After 20 to 30 minutes liquefaction, mix the sample homogeneously by using transfer pipette. And samples should be seen for volume, viscosity, and pH. And good and reliable semen analysis results from semen collection. So these are pass urine abstinence 2 to 5 days, pass and swab, keep the sample at body temperature and deliver within 1 maximum. And this is the WHO criteria 2000. Semen at least 1.5 ml, 15 ml sperm concentration, and 39 total sperm number for ejaculate. Progressive motility should be 32%, motility should be 40%, and vitality 58%. And think about sperm morphology. Only 4% is adequate for normal fertility. And the mixed evolution reaction immunobit test would be less than 50. So these are parameters agreed and consensus. So there is certain terminology, oligospermia, asthenospermia, teratospermia, because of time I'm not going into, because teratospermia, which is causing a really problem day by day, it out. And pyospermia, when there is pause in the sperm, and necrospermia is which all the sperm are dead in over when you see under Meckler's syndrome. And this is WHO criteria also: appearance, then your viscosity, then volume, and then pH. It has to, because low volume reflects a problem with the seminal vesicle and prostate, and acidic pH in a low volume and dense and supplement indicates congenital bilateral absence of vas deferens. So each parameter has its own significance. So coming to examination, then microscopy examination, liquefaction, the breakdown of the gel portion of the seminal plasma. Semen is normally ejaculated coagulum liquefied within 20 minutes. And if heterogeneous mixture, liquefaction is not complete, and is homogeneous, the liquefaction is complete. And if after 2 hours the specimen is not liquefied, proteolytic enzymes such as alpha chymotrypsin may be added to allow the rest of the analysis to be performed. So the measured by drawing releasing semen from using the scientific scale. The normal sample is the drop will form a thread about 2 centimeters long, but in 4+, not aspirated into a plastic vessel. They add equal volume of sperm media following the repeated pipette, and if viscosity is higher, repeat gently passes of specimen into pipette several times. These are small things that you have to take, and it is usually seen under 20 times Meckler's chamber. And when you counting a sample of oligospermia that is less than 15 million per ml, all 100 square has to be counted, and that is the key. Then coming about motility, graded from A to D. Grade A fast progressive that we want, grade B is slow progressive, grade C is non-progressive, and grade E is immotile. So immotile spermatozoa are to be counted in a defined number of squares, and after that the motile spermatozoa are counted and classified into 4 categories. So accordingly, this has to be a grade A to D, and grade A we usually require for a good for assay reported technology or a good embryo. We want a grade A fast progressive motility. Then different categories of motility. There is a progressive motility, there is a non-progressive motility, and there is immortality. That is no movement. If the motility is less than 50%, then the vital test must be done. And if the motility is 0, then pentoxyphylline stimulation test is required whether the sperms are vital or not. And in case of presence of sperm, agglutination, some immunological reaction, that's aggregation and agglutination. Then agglutination has been graded grade 1, grade 2, grade 3. And these are the sperms because there might be agglutination from head to head, from tail to tail, and also tail tip to tail tip, and mixed rectangle. So these are abnormal sperms which have fertility issue, which is concerned with fertility issue. If comes in, then first scan the whole, and if there are any motile and immotile spermatozoa, then you have to concentrate samples and scan under 400 magnification. If azoospermia, then you have to go for fructose label, because the integrity of vas difference and seminal vesicles, because the seminal vesicles secrete fructose, which gives nourishment to the vitality of the sperm. So if azoospermia, then fructose has to be taken. If the fructose is present, there is no seminal vesicle obstruction. Then a drop of sample is placed in the sterile glass slide, and these are the normal morphological form: head, which is the acrosomal region, and then neck, the midpiece, and tail. And the right side, so these are abnormal sperms. The defects, the hair defects may be, tail defects may be, then there may be multiple defects, there may be agglutination, there may be post-cell, there may be debris. So all this has to be taken into account. So sperm must be stained for an accurate staining of the sperm. So strict criteria that we use Street, Kruger, or Tigerberg criteria. The sperm head is oval, smooth, symmetrical outline, length of 3 to 5 micrometer, and width of 2 to 3 micrometer. The head should have a well-defined acrosome area of 40 to 70% of vacuoles that occupies 20% of head area. The mid-piece must be straight and slender. The tail must be straight. And to be classified as normal, sperm must be normal in all portions: head, mid-piece, and tail. So these are the norms. Then there are diffusion quick staining, because if you stain moderate differences of structures, the acrosome is stained red, the slides are fixed with fixative, and it is left for dry by standing the slide on one end to observant paper row, and sperm stains by deep quick are larger by comparison to hematoxylin used in staining. So these are the abnormal sperms, like globospermia, triple head sperm, acrosome reacted sperm, sperm with no acrosome, or sperm with a tapering head and swollen midpiece. So these are abnormal sperm with an abnormal morphology, which has a great fertility concern. And the morphological assessment, which is very much essential for the embryo, for implantation, because most of the morphological abnormalities related to recurrent implantation failure, and it is most important for assisted reproductive technology and IVF peoples. So the percentage of natural correlated with the fertilization rate in vitro and pregnancy rate. Sperms with defective heads are more likely to be immotile than sperms without defects. And defective motile sperms tend to sluggish motility as compared to normal sperms.
Excuse me, sir. Sorry to interrupt, sir.
Coming to vitality, then these are the vitality assessment. Dead sperms are stained peak red, and live sperms are shows curling tails. Eosin nigrans and dead sperm stained pink or red. Eosin dead sperm, trypan dead sperm stained blue, and hypoosmotic swelling test, live sperm shows tail curling. And test 1, 2, 3 are diagnostic uses. Usually 1:1 ratio of semen to dye mixture, mix well and smear onto a slide. Therefore, the viable sperms may be selected for basically for ICSI, intracytoplasmic sperm injection. So this is the importance of vitality in relation to fertility issue in case of a male factor. And these are the dead sperm which are stained pink or red with eosin. Thank you for patience here.
Thank you, Dr. Narhari. You have very wonderfully told all the aspects of semen analysis.
Thank you, sir. And thank you, Dr. Amita Tripathi, ma'am, for chairing the session. Our next session is ovarian reserve. I invite Dr. P.N. Mohanty, ma'am, to chair the session. We welcome you, ma'am.
Good morning, everybody. Hello, is my audible? Good morning, everybody. Can we ask a question now? Can we have discussion now? No.
Yes, no, ma'am. After the session, ma'am.
Okay.
Hello? Hello. Can you hear me? Can you see me?
Ma'am, you're visible and audible, ma'am.
Okay, thank you. Thank you. Let the next session start. Hello. And this.
Yes, ma'am. I request Dr. P.N. Mohanty to invite our next speaker, Dr. Sukumar Barik.
Yeah, Dr. Sukumar Barik, please come and please speak.
Respected Chairperson, distinguished delegates, ladies and gentlemen, it's my pleasure to participate in this national conference, and the next 12 minutes, my talk is on ovarian reserve. Few basics in this area. This is one of the ovarian follicle number, as we know, that at fetal life at 20 weeks, this is the highest number, 7 million we had. But gradually at the time of birth, there is a sharp decline, and about 80% of the ovarian follicle become atretic, and you get around 2 million around the time of birth, and subsequently at the time of puberty, there is only 60 to 80,000 follicles. This is a very important slide showing that ovarian follicle development from the primordial follicle to the antral follicle development and subsequently having ovulation. So every ovarian follicular development or menstrual cycle is basically a preparation for pregnancy. And as we know that ovarian follicle reserve test is basically the number of oocytes remaining in the ovary. That means it is basically with the oocyte number. It is quite different from the oocyte quality, which is basically the potential of a oocyte to result in a live-born infant. So it is a difference of quality and quantity. So if you look at the ovarian reserve test, there are 4 important groups. One is clinical. That is most important thing is age. There are 4 biochemical tests: basal FSH, basal E2, anti-Mullerian hormone, inhibin B. The biophysical or ultrasonographic test is antral follicle count, ovarian volume, and ovarian blood flow. There are dynamic tests, which is not very much done nowadays. For our talk, we'll concentrate into 3 things: age, AMH, and antral follicle count. This is one of my very favorite slide, and it is to be displayed in any gynecological clinic, that the relationship of age with the fertility. And this is very, very important to note that at the age 20, the fertility is probably at the highest. There is a decline, small decline till the age of 30. But look at this, from 35 onwards, there is a sharp decline in the fertility, and there is a sharp increase in the spontaneous miscarriage. So anytime the grandmother was right that age of the female is a very important factor, needless to say that. This is an important document, I think, published only few months back on ovarian reserve, testing and interpreting the measures of ovarian reserve. The anti-Mullerian hormone has been discovered by a French endocrinologist, also known as Mullerian inhibiting substance. It is a glycoprotein hormone, belongs to the transforming growth beta factor superfamily. In male, it is produced by the Sertoli cell, which inhibits Mullerian development. And in female, it is produced by the granulosa cells of the preantral and antral follicles, which regulates the folliculogenesis by inhibiting the recruitment of the follicles. It is very important to know the AMH is gonadotropin independent, and that is the reason assessment of AMH can be done at any point of time of the menstrual cycle, unlike the FSH and LH. The most important use of AMH is for ovarian reserve test for subfertility, but it can be used for the assessment of menopausal status, can be used for assessment of PCOS where the AMH is high. It can be used in uncommon situations like disorders of sexual development, and also can be used in uncommon situations like diagnosing and monitoring granulosa cell tumor. This is the basic chart showing that normal is about 1.0 or more, and less than 0.03, 0.3 is known as very low. If you look at the antral follicle count on the RN, there is a good document publishing how to count the antral follicle in the by ultrasonography, and this is in the left side is the normal one showing 6 to 10 antral follicles in the day 2 or day 3. Whereas in polycystic ovarian syndrome, there is abnormal. There are so many follicles which are in polycystic ovarian syndrome. This is showing that 4 to 10 is the normal follicle count, that is follicle number per ovary. But overall, 9 to 19 is known as, if you take total antral follicle count, then 9 to 19 is the normal number. There is a few advantage of doing transvaginal scan to count the antral follicle count, because you can see the positions of ovaries, you can see the presence of endometrioma or other ovarian lesion, you can see the fallopian tube, whether there is a presence of hydrosalpinx or not, and at the same time, you can see the presence of endometrial polyps or submucous fibroids. The million-dollar question is, which one is better? We have to remember these biochemical or biophysical tests are there, but age is the much more stronger predictor than these two. But at the current moment of the science, multiple studies has shown that antral follicle count or antimalarial hormone are equivalent. And in fact, this we know some of them are using the Poseidon criteria, and there are 4 groups which is showing the which one is the better one, and it is not to show the ovarian reserve, but this is to predict the low prognosis, and this is used by some people. This is an important study published very recently in the White Journal of Ultrasound, Obstet and Gynecol, showing that proportion of the ovarian desired for ovarian response, whether you use antral follicle count or antimalarial hormone, are very similar. So, ladies and gentlemen, at the current moment, if you use antimalarial hormone or antral follicle count, this is the simplest, most sensitive and specific measures of ovarian reserve. The markers of ovarian reserves are good predictor of oocyte yield, ladies and gentlemen, but they are very poor independent predictors of reproductive potential. That has to be understood. And that is the reason it should not be the test for fertility test. So somebody who has got a low AMH should not be denied or told you don't have a chance, because that is basically a quantification. So they should not be denied to have the access of infertility treatment at the current moment. Age, antimalarial hormone, and AFC should be taken in consideration. And the end, I want to say that life is not about quantity of friends you have. It is the quality of the friends you have is the important. So when you are talking about ovarian reserve, antral follicle count is the quality which matters rather than the quality. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Sukumar Parikh. You spoke very well, exhaustively about, give us an idea of the overall view of the assessing the under particular count and AMH and FSS and taking everything into account. You've spoken very well, and it should be open for discussion later on.
Thank you, ma'am.
Thank you so much, sir, for your beautiful presentation, and thank you, ma'am, sharing the session. Our next session is on, our next speaker is going to speak about surrogacy and the present law. I welcome Dr. Supriya Jaiswal. Dr. Supriya Jaiswal is a chief consultant at SM Hospital, Patna. She is a communicator of National Isoparb Executive Committee member, Isoparb Patna chapter, and she has many publications to her credit. Her special interests are in high-risk pregnancy and preventive oncology. We welcome you, ma'am.
Okay, thank you. A very good afternoon to you, all of you. Can you hear me?
Yes, ma'am, you're audible.
Am I audible? Okay,
You're audible, ma'am.
thank you.
There's a slight disturbance in your connection, ma'am.
First of all, I thank everyone. Okay. Now is it okay?
Yes, ma'am.
First of all, I thank the organizers for giving me this opportunity to share this, present this talk on surrogacy, especially Dr. Tapan Patnaik. And I wish Isoparb this conference grand success. So may I start sharing my screen? Can it be seen?
Yeah, yes, ma'am. It's visible, ma'am.
Please start.
Can you see the screen?
Ma'am, it was visible, but it's not visible now, ma'am. Share your screen, ma'am.
Now?
Yes, ma'am. Yes, ma'am. It's visible now, ma'am.
Okay. Yeah. So I'm unable to move it. Yeah. So surrogacy and the present law. I'll take you through the present law basically. Surrogacy means an arrangement in which a woman agrees to a pregnancy achieved through ART in which neither of the gametes belong to her or her husband, with the intention to carry it to term and hand over the child to the person or person for whom she is acting as surrogate. Surrogacy, there are certain indications. Women with abscess of uterus, women with huge fibroid, severe adenomyosis, women with hysterectomy for various reasons, women who suffer repeated miscarriages, repeated IVF failures due to non-receptive uterus, women with certain medical conditions, severe heart disease, kidney disease, women for whom the prospect of carrying a baby to term is very remote, single father, single mother. Surrogacy is regulated in India under these, is it okay? Surrogacy is regulated in India under these legal instruments as following. Indian Council of Medical Research Guidelines 2005, Assisted Reproductive Technology Bill 2010, Law Commission Report by Government of India, Report number 228, Need for Legislation to Regulate Assisted Reproductive Technologies Clinics as well as Rights and Obligations of Parties to Surrogacy, year 2009. Home Ministry Regulations on Surrogacy in January 2013. So ICMR Guidelines 2005 says, these have been drafted by Indian Council of Medical Research for regulating the conduct of ART clinics offering surrogacy in India. This guideline prescribed conduct and use of assisted reproductive technologies, procedures, or treatment by the fertility clinics. This was a precursor to the ART bill practiced by clinics, but these guidelines are only recommendatory in nature and not legally binding. It has been drafted by a drafting committee appointed by the Ministry of Health and Family Welfare, Government of India. Some of the relevant provisions of bill proposed to regulate of the surrogacy agreement in India are Assisted Reproductive Technology Regulation Bill 2010. The bill legalizes commercial surrogacy in India. Assisted Reproductive Technology Regulation Bill 2010, among other things, primarily legalizes commercial surrogacy by providing for payment as monetary compensation to the surrogate mother by the intending couple for agreeing to act as surrogate under surrogacy agreement, which is enforceable in law. The bill provides for the conduct of surrogacy through surrogacy agreement. There should be a surrogacy agreement entered into by the couple or individual seeking surrogacy, and the surrogate mother shall enter into a surrogacy agreement which shall be legally enforceable. So the bill provides for National Advisory Board for Assisted Reproductive Technology as well as State Advisory Board and State Registration Authority. The bill provides for the setting up National Advisory Board for Assisted Reproductive Technology as well as State Advisory Board to supervise the conduct of ART clinic and ensure compliance with the mandate of ART bill and State Registration Authority, which shall grant a certificate of registration to the ART clinic for their functioning. The bill stipulates the eligibility criteria to be satisfied in order to avail ART treatment in India. So in order to avail ART treatment, including surrogacy, the intending couple must be 21 years and none of the ART treatment or techniques must be performed on a person below 21 years. The surrogate mother, the gamete donors, either as oocyte or sperm donor, must be 21 years in order to be eligible to be donors or surrogates. The bill lays down certain preconditions in order to be surrogate mother. The bill fixes the eligibility age as minimum and maximum age for a woman to act as surrogate mother as 21 years of age and over 35 years of age respectively shall be eligible to act as a surrogate mother under this act. Further, it states that a woman shall act as a surrogate only up to 5 successful live births in her life, including her own children. Only Indian citizens shall have a right to act as a surrogate, and no Indian surrogate mother shall be received or sent abroad by ART bank or ART clinics. The bill stipulates that duties to be compiled with by the surrogate mother. Surrogates shall be duty bound not to engage in any act that would harm the fetus during pregnancy and the child after birth, until the time the child is handed over to the intended or commissioned parents, designated persons. The bill provides for insurance for surrogate mothers subject to availability. The bill provides for payment of all expenses, including insurance, during the period of pregnancy and after delivery, if available, to the surrogate mother by the intending couple. A child born to the married couple through the use of assisted reproductive technology shall be presumed to be the legitimate child of the couple, having been born in wedlock and with the consent of both spouses, and shall have identical legal rights as a legitimate child born through sexual intercourse. The birth certificate issued in respect of a baby born through surrogacy shall bear the name of individuals who commissioned the surrogacy as parents. The names of intending couples will be stated as parents of the surrogate child, not the surrogate mother. The bill provides for relinquishing the custody of surrogate child by surrogate mother, egg donor. The gamete donor, surrogate mother shall relinquish all parental rights over the child which may be conceived from his or her gamete. The bill mandates intending couple to accept the custody of surrogate child. The person or persons who have availed of the services of a surrogate mother shall be legally bound to accept the custody of the children, children may have, and the refusal to do so shall constitute an offense under this act. So the bill provides for foreigners to avail commercial surrogacy in India. So the bill provides for foreign intending couple or non-resident Indian individual or couple to avail surrogacy in India after submitting necessary documents, which include a letter from either the embassy of the country in India or from the foreign ministry of the country, explicitly stating that the country permits surrogacy. The child born through surrogacy in India will be permitted entry in the country as a biological child of the commissioning couple or individuals. So the bill provides for appointment of a local guardian. The foreign intending couple or non-resident Indian individual or couple seeking surrogacy in India shall appoint a local guardian who will be legally responsible for taking immediate care of the surrogate mother during and after the pregnancy, as well as to take immediate custody of the surrogate child if the foreign intending couple seeking surrogacy fails to take delivery of the child. The guardian is responsible for the custody of the child till the expiry of the period of 1 month, after which the guardian may hand the child over to an adoption agency or alternatively may adopt the child himself. So the bill ensures privacy of parties availing ART treatment in India. The bill ensures the confidentiality or privacy to be maintained with respect to the donors as well as the surrogate mother. The bill prohibits prenatal determination of sex of surrogate child and makes it a punishable offense. The bill prohibits conducting of prenatal diagnostic techniques on any pregnant woman in order to determine the sex of surrogate child before birth. So there are different consent forms for this: Form D, IVF-XC, Form I, Form J, Form K, M, M. So there are different issues like agreement for the surrogacy, consent form for the donor of eggs, information on egg donor, and for M for information on surrogate. Different consent forms result. Yeah.
Ma'am, you're running short of time, ma'am.
Okay, finished. It discusses the rights and obligations of the parents to surrogacy. The report recommended for legalization. The report recommends for obtaining full informed consent from the surrogate mother, life insurance for surrogate mother, thus it seeks the protection, the interest of the surrogate mother. So this is the Home Ministry guidelines. And finally, the new journey is going to begin soon. The Surrogacy Regulation Bill 2020 is an ethical, moral, and social piece of legislation which protects both exploitation of the surrogate mother and the rights of a child born through surrogacy. One of the bill's most noticeable features is that it has continued the ban on commercial surrogacy. The bill predominantly proposes to allow the ethical surrogacy to intending infertile couples. So this is the final bill that has come. Thank you very much. Thank you for the patient hearing.
Thank you so much, ma'am. We have 3 minutes now for discussion. I request Dr. Amita Tripathi and Dr. P.N. Mohanty ma'am to kindly discuss and conclude the session.
Hello.
Ask now. Can I ask now? Am I audible?
Yes, ma'am, you're audible, ma'am.
Hi, good morning, everybody. Fantastic arrangement by Tapan and group. Congratulations to the Isoparb Odisha chapter and the national conference. I am so happy. Yeah, I have missed my, I am an examiner today, but missed few hours for my topic today. My question is to a seminal analysis, whether CASA is required or only seminal count will do. What is the advantage of CASA, computerized assisted seminal analysis, over the normal seminal analysis? We want to know. Norari Augusti. Hi, Dr. Norari. Or Madam P.N. Mahanti can tell us also.
Yeah, CASA is very good morning to you, ma'am. CASA, of course, is another great help in determining the quality of the sperms and exhaustively and I think decisively to give you the quality count and the quality and quantity of the sperms as well. But then if in the absence of CASA, most of the centers are functioning without CASA. There are few centers.
Normal seminography, if there is any doubt or anything, any abnormal, then we can offer that. It is little costlier in our place. I know about you all. It's not available in the medical college. And if you do outside, little costlier for that one. Okay, for that. Thank you very much, madam. Sadhana madam, good morning. And very good morning.
Good morning.
Nicely as arranged, he told that he will be recording and doing all these things. And what about where is Dr. Sukumar? He has presented very nicely the topic. Yeah, very nice on ovarian reserve. And you have told that only 3 things is required, and you don't have to. Age is the main factor. So, do you require to do an AMH in case of infertility with endometriosis and infertility with PCOS, where you are doing LOD, whether it is required or not?
It's a very good question, ma'am. I think for endometriotic surgery, when you are doing for ovarian endometriosis, it's a good idea to do AMH beforehand. The reason is very simple, that if you do endometric surgery and subsequently the AMH comes low, then the blame comes on the surgeon, the laparoscopic surgeon. So it's a good practice, although it is not, the guideline doesn't suggest so. It is a good practice to do AMH before laparoscopic surgery to know the ovarian reserve, so that you can compare between these things pre and post surgery.
And in LOD, how it is helpful in laparoscopy ovarian drilling? I'm very fond of LOD, but nobody agrees. But personal experience is very good. What should you do or not?
I'm very skeptical. I'm very skeptical about laparoscopic ovarian drilling. I know many people are very fond of laparoscopic ovarian drilling. Laparoscopic ovarian drilling has got a very specific, precise place in infertility. The use and abuse of this thing is much more, abuse is much more common. So it is
rightly done, no abuse. My personal experience for 30 years. If you are 40 watt, 4.4 second, and if you have induced early, you do. But my question is that whether this AMH is a little high in case of PCOS, also it has been studied that it comes little low down after doing a LOD. Is it beneficial or not? We should do or not?
You can say that yes, in case of PCOS, there is high AMH. After doing LOD, it can come down. But whether it transforms into the ovulation and good quality ovum, it's a debatable thing to say. But again, I'm re-emphasizing that LOD has got a definite place in infertility management, but it is a precisely indicated group. It is very helpful.
Thank you very much.
And I agree with you, Madam Mishra and Dr. Parikh, that the abuses connected with the LOD is much more than the
benefit
uses. But then I want to give one point here, put in one point here, that in PCOD, ordinarily it defies the age bar. Like at 35 years of age, if the count comes down, but here it can extend up to like good quality eggs can be there in good quantity also up to 40 years. stage. So that is the beauty of PCOS also when IVF practice is done.
Thank you all the madam and sir and speakers.
Thank you, ma'am. I thank all the chairpersons and the speakers. I'm sure the information provided was highly beneficial to all our delegates.
Thank you very much for giving me the opportunity to speak, also to participate. Thank you so much, Dr. Patnaik especially, and Isoparb. Thank you.
Thank you very much, ma'am.
Thank you, ma'am. Thank you very much. Thank you, Sadhana, ma'am.
Our next session will be the keynote address, for which I would like to invite our distinguished chairpersons for the sessions, Dr. L.K. Pandey.
Good morning.
We welcome you, sir. Professor Dr. L.K. Pandey is the ex-professor and head of Obstetrics and Gynecology, Institute of Medical Sciences, Banaras Hindu University. He has more than 90 national and international publications, and his special interests are in reproductive medicine and ultrasound. We welcome you, sir. Our next chairperson is Dr. Jasmina Das. She is a professor and Department of Obstetrics and Gynecology, IMS and Some Hospital. She has several publications in national and international journals to her credit. Her areas of interest are high-risk pregnancy and fetal medicine. We welcome you, ma'am.
Namaskar and welcome all you esteemed faculty.
We will be starting our first keynote address on the topic optimizing IUI place and outcome in infertility management by Dr. Sadhana Gupta. We welcome you, ma'am. I request Dr. L.K. Pandey to kindly introduce our speaker.
Ladies and gentlemen, it gives me immense pleasure to chair this session of this conference. Information has been used for a long time.
Sir, excuse me, sir, you're not audible, sir.
Just 1 minute, Bolo. I'm correcting this.
Actually, sir, voice is breaking. Dr. Shashmita can introduce, I think, now, so that we can start.
Hello.
Hello.
Is it audible?
Yes, yes.
Yes, ma'am.
Let us move, Shashmita, because
Mild male infertility with ovulation induction or superovulation. Insemination with donor sperm is effective both in natural cycle and stimulated cycle. Patient fallopian tubes are prerequisite for intrauterine insemination. Dr. Sadhana Gupta is a well-known figure in India. She is from Uttar Pradesh, Gorakhpur. She has been to various offices of OPSI. She is presently. Can you project her figure?
Yes, ma'am. Yes.
Hello.
Yes, ma'am.
Kindly flash my CV on the screen. Sir is getting some problem.
Sadhana madam will be the future. She is the future president of Oxford. That is so many clear that if you allow me, I'll be telling it will go one day. So let us start and listen to them.
Yes.
Welcome.
Yes. That's it.
Yes.
I'm just sharing my screen, and the Shashmita can, you can.
These projects have CV.
I've sent CV long ago. So I think with the permission of chairperson, can I start my presentation?
Hello. Madam, please start. Everybody knows you. Please start.
Yes. So today with the wonderful pre-session on the infertility, we are going on roll on and the topic given to me is the optimizing IU. What is its place in infertility and how to optimize? So my all namaskar to Jagannath ji, and we cannot be there personally, but we really miss. So I've been greeting from Foxy, Sapog and ICOG, and it is a little bit about me, which I've got lost. So infertility is what we all know. When after period of 6 months to 1 year, patient is having unprotected intercourse, but they are not being able to conceive. But still defining infertility is complex and mapping the problem, because you have to map the infertility management and we have to create a roadmap. That is a one important message which we want to give, not go zigzag. You create a plan for infertility in every management. So that is the amount of magnitude. I request everybody to mute so that I accept the speaker. So there is a good magnitude of infertile couple globally and India, and it is a global public health problem. I request organizer to please. I request organizer to please mute everybody.
Yes, ma'am. Yes, ma'am.
So it is a global health problem. And we are having a complex modern world because people are delaying physiological function of reproduction. There is a expect mechanized and prompt result or every treatment. They worry a lot, more substance addiction, and there is a combination of treatment. And what as a OB/GYN and infertility specialist, what are our concerns? Because we have the perceived competition among ART clinic, financial and commercial pressure for setup of ART lab, legal and ethical issues on the horizon, and we know that there is always an unpredictability whether this couple will conceive whatever you do. So what is IUI? We have to follow the nature. Where is the IUI place? We are following the nature. We are being natural and we are being patient, and we understand the patient needs. We individualize the patient treatment and give realistic explanation and expect also realistic expectation. So IUI, we know it is one thing. Mild stimulation remains with the insertion of prepared semen into the female reproductive system. So what is the place of IUI? It is the point of discussion which I will be taking upon. So it is a method by which semen or sperm are placed into female reproductive system, usually uterus, by a mean other than intercourse. If it is done by husband or the partner, it is AIH, or it can be donor insemination. So a long ago from the animal husbandry, actually this all ART came in our practice. And when there was 20th century and suddenly there was so much change in technology, and we have the birth of first IVF baby, and then there has been so much issues in the reproductive system, and IUI has actually been degraded from its place. So IUI is a low technical solution to many or majority of infertility issue, and many times first choice of ART procedure to assist the couple having difficulty in conception. So selection of the patient is most important. When we select the IUI, when we have the cervical factor, when we have a mild anovulation, mild to moderate endometriosis. In male infertility, when we have the mild or moderate oligoasthenospermia, ejaculatory erectile dysfunction, non-obstetric azoospermia, when we do the AID. Unexplained infertility, actually IUI can be the good choice for many unexplained infertility, which constitute about 25 to 35% of all infertile couples. So indications and the selection of the patient for IUI is very important. Some are special situations like partner is not available during fertile period. There is non-availability of sperm due to like cancer surgeries when we have to freeze it, and sometimes HIV and hepatitis C positive. Then we do the timed intrauterine insemination to reduce the risk of transmission to female partner. So the specific indication we have to understand, and the main indication of IUI we have to understand. When we go to the donor spermatozoa indication, donor spermatozoa insemination, we all know non-obstructive azoospermia, very severe oligospermia, but the couple is not willing or cannot afford IVF, then it is important, or the genetic disease in the male which has caused the severe recurrent pregnancy loss. female factor, it is the changing trend, single lady keen on becoming single mother. We have to respect her desire, and it is legally advisable, and even the lesbian couple. So rationality for IUI, we want to bypass cervical mucus barrier. We have a good sperm technique, and it has to be considered. Where it is placed, it is an intermediate step of low to moderate complexity before application of more sophisticated ART technology if the tubes are patent. So worldwide, the people are conscious. Health cost has become a big issue, and IUI is a low cost, very effective method if done in the selected cases. And it is a surprising data from Australia and New Zealand that 80% of centers are convinced with the effectiveness of IUI, but only 1/3 of them promote IUI and only do IVF because of many things. So what are the advantage of IUI over IVF? It is simple, inexpensive, easy to learn, minimal equipment requirement, less invasive, reduce psychological burden on the couple, good couple compliancy, low risk of OHSS, and low multiple pregnancy rates. So there are many advantages, and there is a recent advantage which says that the initiating treatment by the IUI appear to be more cost effective than primary IVF in most cases of unexplained and moderate quality. So this is all that they are easy to run, and we are coming. There's all new studies which shows that IUI have got the specific place, but there has been so much commercial pressure, support of industry, which is actually displacing the IUI from its real place. So what is the selection? We have to think that the ovulatory cycle, it is spontaneous or induced, confirm that at least one patent fallopian tube is there, and motile sperm count should be 5 to 10 million. If it is 1 million or it is very few sperm count, then IUI is not for them, and preferably age of the woman should be up to 36-37 years. Exclude the contraindication, that is cervical atresia, acute cervicitis, never do in the acute PID, bilateral tubal obstruction, very severe oligospermia, and in most cases of amenorrhea, and in age more than 40 years, IUI has got no place. So what is the basic workup? It is simple ovulation monitoring, tubal testing, and the semen analysis. This is the simple. We have to maintain the IUI lab quality as IVF lab. It is not that stringent, but it also requires a quality maintenance. These are the things we need in IUI lab: microscope, counting chamber, laminar flow, test tube former, centrifuge, autoclave, liquid N2 and cryocan for semen cryopreservation. We have to have the wash area, OT area with UPS system, because if a centrifuge is on or you are in test tube former and if the power goes off, then your results are going to deteriorate. You have to have the UPS refrigerator in the lab, and always before and after cleaning and minimal human entrance with full scrub and lab guard are key to sustainable IUI lab. And if you have the IVF lab, it is always better that you separate IUI lab from the IVF lab. So these are the simple equipment which are needed for the IUI lab. We have this disposable. We have to select a good company who provide good culture media, semen collection containers, slides, tissue wipes, pasture pipette, and the falcon tubing. So select your company and believe on it. So what is the semen analysis? It is very important. I think we have done a very good lecture on semen analysis. So I am leaving aside the other thing, but there has been a good question mark on the WHO criteria also for the semen analysis. So what is important, that is the total number of motile spermatozoa after wash is the most important criteria which defines success of IUI. So see what is morphology, and the total motile inseminated sperm is the most important criteria which actually defines which optimize the result of IUI. So I am not going for this thing, and the controversy, abstinence controversy. This is very important. That it should not be more than 7 to 10 days, and it should be minimum 3 days. This is very important because there is chances of immature chromatin which is significantly increased with only 1 day abstinence, maybe because of immature sperm produced after recurrent ejaculation. So it should be abstinence for 3 days. But if you give the sample after 7 to 10 days of abstinence, that sperm has got the not good quality and the good motile sperm. Respectful environment is very, very important. Patients are suddenly, it is all our experience, suddenly they are not able to give the sample, and you can give anxiolytic and sildenafil, and the respectful environment. What should be the technology? Swim up, density gradient, sperm wash. The studies actually doesn't differentiate much, but if it is a good sperm count, more than 40 million, then the swim up technique is better. And if it is a compromise like 10 to 25 million count, then the double density gradient give better recovery of total motile sperm count and preferred in oligoasthenospermia. So double density gradient is important technique if it is oligoasthenospermia, and swim up is good if it is a good sample. So it's a technique and it is a part of like full day workshop, but we must know that in what patient, what technique should be, and train yourself and your 1 or 2 staff in making the good preparation of IUI. That is very important. Another important point which I want to communicate is that sperm, when you have done the IUI, you have prepared the sample, you insert that IUI sample within 30 minutes, within as soon as possible, because you start semen processing within 30 minutes of ejaculation. It takes around 45 to 60 minutes to prepare, and give as soon as possible. You insert the semen sample into you do the IUI, because the sperm, these activated sperm like use energy in a very rapid way, very fast way, and they tend to lose energy if you like have the gap. So never give this advice that you prepare IUI preparation, semen preparation at pathology and you are doing in your lab. It is strongly not recommended. What we say again, prognostication, total sperm, motile sperm less than more than 10 million is a good in the prognostic rate. A donor insemination rule, I think we have done it in the previous section, but it is important that you follow all the ethical rules and the legalities. Female factor in IUI, age is not just a number. What we say, the female age seems to be an independent factor in predicting pregnancy after IUI. Studies show significantly less pregnancy rate after age of 35. So beyond 35, you should be a little careful for choosing the IUI as a procedure of the choice. Success of COH IUI is higher in anovulatory and unexplained infertility as compared with endometriosis and moderate to severe male infertility. This is important to know that in unexplained infertility and in anovulatory infertility, we have got a good result. So we do the COH, we can do the ovulation aromatase inhibitor, or we can do for the clomiphene cycle added with gonadotropin. So what is difference between IUI and IVF? In IUI, we want only 1 or 2 or 3 follicle maximum, and in IVF, we want the multifollicular development. So we have to be very, very careful with our ovulation induction, and rampant use of gonadotropin for IUI and the control ovarian stimulation is not recommended. The another point which I want to know, that with the clomiphene cycle, the selection, the IUI timing should be done when the follicle is around 18 to 20 millimeter, but if it is a gonadotropin added, then 16 to 18 millimeter follicle size is okay. So there is a difference, and there is no study difference between anti-estrogen and aromatase inhibitor and gonadotropin. But if the patient is not having result, or patient is not having good follicle, then addition of gonadotropin 150 IUI HMG from the 7th or 7th day, 9th day, or 7th, 8th, 9 days is a very good add-on to increase the success of IUI. But there has been the issue of cost, close monitoring, so you have to individualize the decision. So there has been so many studies which shows that gonadotropin addition increase IUI efficacy and the success, but you have to have considered the cost, repeated scan, and the chance of ovarian hyperstimulation. So the takeaway, use of gonadotropin only in CC resistant PCOS case, and when the pregnancy is not achieved with use of oral ovulation induction. And when you are using gonadotropin, use lowest possible dose. Always aim for mono or bifollicular development. If more than 3 follicles, more than 16 millimeter size, we should not go ahead with the IUI. Premature LS surge is a problem in sometimes in IUI also, and it is said that premature LS surge is actually indicative of the poor oocyte quality, or it is more frequent in older women because their maximum follicular diameter at the time of ovulation is substantially smaller. I think we all share that we are following the follicle and it is 12 millimeter, and when we are expecting 14 millimeter follicle, there is a suddenly follicular rupture or disorganized follicle. This is due to premature LSR, that it can occur in 25 to 35% of stimulated IUI cycle, which may interfere with timing of IUI as well as lead to treatment failure. So we should be a little cautious of it. We cannot predict it. You only follow and then you can think that this patient is having this problem. And sometimes the addition of GnRH antagonist, that is cetrolix, add to like solve this problem. When the follicle is around 12 to 14 millimeter, you add cetrolix or the GnRH antagonist and you follow, and sometimes it really helps. However, current evidence does not support the routine use of antagonists in IUI cycle to improve outcome, and only individualization is the key. But we have to know that it is the possibility. You have to follow carefully and you have to individualize when you want to give GnRH antagonist or not antagonist. So the individualization is very, very important. When to give ovulation trigger, as I say, in CC pregnancy related diameter of follicle may be larger. You should give around 18 to 20, while the gonadotropin, it is 17 to 18 millimeters. So I have got 2 minutes. So at the time of LSS diameter, it should be 17 to 20 millimeters. Periovulatory follicle looks like it, and you can give SCG. Usually the drug of choice for ovulation trigger, it is 5,000 to 1,000 IUI. Synchronization, when you want to give, you can do IUI after 24 to 36 hours. Usually we do after 36 hours, but we want to know for the newcomers that you can have the flexibility, and don't think that you have to get at 32 hours, 40 minutes. It's not so. You can do 24, 36 and the 38 hours. A little bit, we don't inject more than 0.2 to 0.5 ml of the prepared semen. This is very, very important. All aseptic precaution and all the things, all the protocols for the IUI, for all the things are that no use of Savlon, betadine, only normal saline. You have to be very slow. Choose usually flow catheter and wash is injected very slowly and very rampantly. If there is a resistance or if there is regurgitation, you have to straighten the cervical angle. Sometimes the full bladder acts, and when you just rotate the IUI catheter in the tube, if it is twisted, then it will come back. So you have to be very careful about the regurgitation, about the ability not to negotiate into the cervix, and you should be handy with the Alice forceps so that you can handle cervix. You allow the patient to have come with the full bladder, and you have to be very slow and steady in the procedure. So when there is troubleshooting, and sometimes the firm IUI catheter also helps. So post IUI management, luteal phase support studies can say, because we are not doing that, the down regulation and then the up regulation, but usually we give the luteal phase support in form of vaginal progesterone or sometimes oral progesterone or dihydrogesterone we give, and it is a good choice. In case of thin endometrium, if you are following, then the exogenous estrogen may be needed, and whatever we need do for the IVF, that is aspirin, arginine, they can be used for the thin endometrium. So the complications, it is a very, very important standpoint for the use of IUI. It is almost complication free. You cannot have OHSS, less number of multiple pregnancy, no painful, and very low risk of the ectopic gestation. So this is very, very important ethical and legal issue. I will cover a little, because it is considered, IUI laboratory are considered level 2 facilities. They need TBS facility, semen collection and processing, registration under PCP. I am finishing just. Yes. So modern world has, this is all the tubing. Never and never promise any sex selection, and post-human IUI is important. How many cycles? Only 3 to 4 cycles, and we need a very high research in IUI. This is a neglected field for the research, and these are all things which we all can do the research and come with evidence in the in our country. And to conclude that it is a very, IUI has got a very important place. Select your patient well, select techniques, maintain your IUI lab quality, and you will have a good result. Thank you very much. and let's work together, and let's hope that we will come physically to the Nagari of Lord Jagannath and pay our and receive our blessing from the Jagannath. Thank you very much.
Thank you so much, ma'am. Thank you so much for such an elaborate and beautiful presentation. We have our next session, a keynote address on ovarian tissue cryopreservation by Dr. Bharti Mishra. I kindly request Dr. Sasmita Das, ma'am, to kindly introduce Dr. Bharti Mishra.
In the meantime, we'll go for discussion a little bit with madam.
Ma'am, post this session, ma'am.
Because I have to run to exam. I am the internal.
I will really like to have a few comments from the chairperson.
You just put it. I'm just asking madam. Very nice talk. 1 hour talk. She has precised to 20 minutes. Great speaker. Madam, suppose lady of 40 years married. You told that it's contraindicated after 40 years. So, and the tubal factor is okay, ovarian reserve is okay. Can we not try IUI before going for IVF or anything else?
Very nice question. Dr. Bharti, what I usually consider, actually, if it is primary infertility, we don't consider it. But if it is secondary infertility, patient is having first child 10 years ago or 8 years ago, then we say that the success rate may be low, but we can try, especially in the fertile women. And
costly and result are same. If there is no other factor, ovarian reserve may be good, because all are marrying late nowadays. But that isn't. It's not an absolute contraindication. It's a relative contraindication. I think so.
Yes, it is not contraindication. It is not a procedure of first choice, and we have to counsel the couple that we can try for 1 or 2 cycles, and actually we have got the result of the pregnancy in 39-40 years sometimes. So we have to be clear in the counseling as well.
And I always like to all conferences and to be clear my queries. Students, bear with me. So madam, second is that when you are doing IUI and follicular development, at the same time, are you seeing for the endometrial thickness, or you do IUI and give support to the endometrium?
If there is follicle development, yes. If there is follicle development, what we say, sometimes we get the early follicular development, especially with the gonadotropin. On day 7, you got the 15-16 millimeter. And endometrium is not that it is only 0.5 and it is 5 or a little low. Then what should be done is we should wait for a while, like call the patient after 24 to 48 hours, then look for follicular growth and the endometrial pattern. But if the endometrium is constantly thin and the follicular is 17, 18, 20 millimeters, then we should do the IUI and we should continue with the estrogen as well as the progesterone.
You have a experience with sildenafil and aspirin and other.
They are good. They are good. Aspirin is very good. It is a routine and it is a cheap drug also. And we add sildenafil routinely in the IVF, and sometimes when the endometrium is thin, we can use it vaginal sildenafil also.
Thank you, madam. Thank you, madam. And then come my talk, please. So.
Bharati madam is not at, really no one, she is not at all unknown to this forum. She is always the active participant in all our conferences and workshops. Only this is a formality to introduce her. Okay. She is the professor, MKCG Medical College. Now she was previous HOD there also, and she is the receiver of Wonder Function Award for this year 2020. She is fellow in IVFET Boston, USA. She is life member of many bodies, FOXY, Isoparb, IMS, IAG, and she is a very active member of FOXY, and she has many role in health education programs, Rotary health education, many aspects. And please start, madam. You have a very new topic you have to introduce to us, like ovarian cryopreservation. We will just learn from you. Thank you, ma'am. Please start.
That means you have recorded it, so no? Good afternoon, everybody. First, I must thank profusely Dr. Tapan and the team for doing the virtual meeting of Isoparb, which was scheduled 1 year back. So, dear friends, today I have to tell something new which is occurring in the fertility. So for female life, as you know, lifespan is the most important thing. If you live long, you can enjoy femininity and fertility. If you live long also, what is required is the femininity, and femininity is done only by presence of ovaries. Ovaries are ornament, and we enjoy all the hormones starting from progesterone, estrogen, androgen, AMH, and even so many hormones second to the pituitary glands, and the femininity is maintained. If there is femininity but no fertility, then there is no use. So what is there? Fertility is the primary objective of every female to have a baby. But when you come to history of preservation, starting from 1776, sperm preservation to 2005, when fresh human ovarian cortical graft transplantation is done between the two monozygote discordant twins. So coming 10% of the new cases of invasive cancer diagnosed in women reproductive age. The majority of cancer treatment may be chemotherapy, may be radiation or surgery. But in few of the cancers and cancers like element, like thalassemia, other things, also bone transplantation is done, where there is a use of lot of gonadotoxic material, and let it be X-ray or anything, and which is harmful impact on the reproductive capacity, causing ovarian reserve and uterine function abnormalities. Coming to ovarian reserve, I must tell one point that at birth in the intrauterine life there is 7 million ova and the follicles. At birth it reduces to 3 to 4 million. At puberty 5,000 to 6,000 and mature. But finally in lifespan of a female only 400, 500 oogonia mature. With one mature ovary, so many atretic follicles are destroyed. So ovary is the ornament, and we have to talk a lot about ovarian reserve. So pelvic radiation like Hodgkin's lymphoma, genitourinary cancer, ovarian follicular damage, subsequent loss of ovarian function. Do you know that 30 to 40 gray is required for a daily for any cancer, but 2 gray can lose half of the oocytes. Considerable interest present in fertility preservation option for women of reproductive age planning for cancer treatment. So I am talking today about the cancer patient who is affected in the early childhood or in the adolescence or in childbearing age, where there is preservation of ovarian tissue for fertility afterwards. As you know that in the genital cancer like cervical cancer, selective fertility restore can be done, and in a case of endometrial cancer, a high dose of progesterone is given and then they are allowed to have a pregnancy. In germ cell tumor or epithelial cancer of 1C, a very early ovarian cancer, you take out one ovary, allow them to pregnancy, then do a treatment and take out. These are the things we do for other things, other genital cancers. But if I tell about ovarian preservation in gist, for the beginner, you have to know about what is ART. In short, the maturation of the control ovarian stimulation, collection of the oocytes, fertilization with the good sperms. After that, embryo is implanted and embryo transfer is done. But if I am telling, I have to also tell few things about freezing. There are so many types of freezing is there. What matters to us is embryo freezing, vitrification, slow freezing and vitrification. You must know the difference. In case of vitrification, there is a cryoprecipitant added to the liquid so that there will be no destruction of the oocytes or a oogonia or the embryos, spindles or the chromosomes. So if there is a slow freezing, it is destroyed. In 0 degree water is freeze. In minus 68 degree, the cell is freezed, and you do a freezing at minus 196 degree. So for this freezing, slow freezing is optimal for ooze embryo freezing. But for ooze site and cryopreservation for ovarian tissue, better is the vitrification, where it forms a layer surrounding the cells and it will not destroy the mitochondria, unlike that of slow freezing. Then thawing is made and it is put in the that one. So focus to the 3 fertility preserving fertility technique. One is ovarian transposition, one is ovarian tissue harvesting for cryo, one is ovarian autotransplant. So ovarian transposition, what is that? Ovarian transposition, to transpose the ovary outside the radiation field. You can take the ovary in the pelvis, behind the uterus, where there will be no radiation effect. Or you can take the ovary outside the pelvic rim, in the lateral abdominal wall or anywhere in the body, so that after finishing the radiation or whatever treatment you have given, you can reimplant to the original position and the patient can conceive. Ovaries are commonly transported to the high lateral abdominal wall above the level of SCs, anterior superior iliac spine, recommended for vaginal, rectal and cervical cancer. Another side is medially behind the uterus. Preferred location cases of planned abdominal radiation. The procedure can be done laparoscopically, laparotomy or by robotic nowadays. So ovarian transfer by laparotomy, if you do, there are 83% patient going pelvic radiation can have a ovarian function. But disadvantage is too many. Long incision, increases of adhesion and post-op intestinal obstruction. So laparoscope ovarian transposition is done nowadays with 88% chance of successful ovarian function preservation. So I told you that the ovaries can be transposed, mobilized behind the uterus, or lateral transposition is more effective. One main consideration whether transpose the fallopian tube or not, that has to be taken into. If the fallopian tube also you are taking, keeping with the uterus, you can have a normal baby. No need of ART or artificial reproductive technique, which is costly and the effect may be detrimental. But if you can keep the fallopian tube along with the ovary, the result are less costly and you can have a normal baby like that. So this is the picture showing laparoscopically a small peritoneal window is made above the pelvic rim. Then the ovaries are caught in the ovarian ligament and caught and transected medially, keeping the tube intact. Laterally, one window is made in the IP ligament so that the ovary can be mobilized. Then the ovary is separated from the fimbrial end, taking care not to injure the fimbria because normal pregnancy you want afterwards. Then there is a tunnel is made below the peritoneum, behind the taking out the ovary to the lateral place. The gently gas ovaries are placed in the lateral wall. They are tucked by 7030 proline, and then there is a tuckering of a titanium metallic thing, so that after 5 years or 7 years of treatment of radiotherapy or chemo, you can again replace the ovary into the natural position. This is in the lateral wall, the picture is showing. Both ovaries can be transposed and they allow spontaneous conception. When you take back the ovary to normal position, then there can be normal conception. Due to high rate of ovarian failure, not usually recommended in women more than 40 years. No need of reposition of ovary for pregnancy to occur in all cases. But in IVF cases, if you do IVF, the ovaries are again reposed to the pelvis. Why? Because the follicular fluids help for the regeneration of the ova. Second thing, that will be when you do a TVS and retrieve the ovum pickup, become very easy. So potential complications are there: ischemic damage of the ovarian blood vessel, ovarian fallopian tube infarction, abdominal pain, ovarian torsion, risk of radiation induced cancer very less, and metastatic gynecological malignancy very less. Ovarian seedling and radiation hazard is very less in this procedure. Then second, so it is a one type when you have taken the ovary, coming back ovary, and you have taken the ova out. Now, second procedure is ovarian tissue harvesting and cryo. So OTC is an emerging fertility preservation and very recent advances for this reason I am presenting. Control ovarian hyperstimulation in the population is challenging. So ovaries are yet to be responsive. See, their babies, 16 years, 10 years, 15 years, girls become succumbing to the radio or chemo. There is no time because cancer lifespan is very important. You have to keep the ovary away and make them pregnancy. There is no time. They will not, their gonads will not respond to hormone stimulation to keep the ovary preserved. Second thing, there is no time. So you have to take the cortical tissue and preserve. So what is that? Let us see. They need high dose of gonatotoxic granule. Patient selection, adult female cancer patient with hormone sensitive malignancy. Hormone sensitive, you cannot induce ovulation. Patient who cannot delay the cancer treatment, standard fertility treatment. Unmarried women without a partner also can have this. Pregnancy and live birth rate following this procedure increasing steadily. The prepubertal children, oophorectomy is recommended. So you can do a oophorectomy or cortical dissection. A longitudinal incision is made in the ovarian cortex. Thin cortex is removed from the ovary, leaving the medulla. Cortical tissue are taken, 1 centimeter strip and 5 millimeter width and put in the media for preservation. You can do a slow freezing or a vitrification. There are two lines of thought, equal result. The ovarian tissue can be frozen during slow freezing and vitrification technique can be also observed. So there is a controversy, but both are seeing the same result. Then there is a transplantation. When the treatment of the patient is finished, there is a team of surgeon and gynecologist and endocrinologist. They will open that the lady or the girl is free of cancer now. They can have a now re-implantation. It is done usually after 5 years or 3 years, whatever required. 130 children were born during this procedure. So re-implantation considered once the patient is disease free and cleared by medical team. So either there are two types. One is orthotopic, autotransplantation. Another is heterotopic. Orthotopic means in the pelvic cavity you do a transplantation. Heterotopic means you can keep the live cortical tissue after thawing in the forearm, behind the breast, abdominal wall, and behind the peritoneum, behind the muscle. So advantage of heterotopic implantation is easier transplantation procedure, no restriction of number of ovarian tissue fragment be transplanted, ovarian, non-ovarian abnormal follicular development quality and not well known. The heterotopic is mostly done, two things I told you ovaries. One is femininity, second is fertility. So femininity is by your ovarian hormones they will provide, and fertility more is orthotopic is required. Orthotopic autotransplantation more commonly done. The medullary bed contralateral ovary can provide ideal environment, ovarian follicular development satisfactory. Major challenge is ischemic damage of follicular loss after the transplantation. There is a lot of use of antioxidant which creates an environment and which give life to the follicles for their growth. Two techniques devised depending on the presence of medullary bed. Presence of medullary bed means again the cortex will be implanted there. So what ovary you have cut, in that case you just implant these strips on the and make it raw and implant this with 70 and 80 proline. And another absence of ovary, you can make a peritoneal window, I will be showing in my video, and put the ovarian cortical tissue and seal it. It can be done in a 1 sitting or 2 sitting, and it is called orthotopic. So this is one very good nice picture. For one, the implantation of ovary can be done here, and the second picture I have shown how in the abdominal wall ovarian cortical tissue behind the rectus muscle and above the peritoneum, where there is vascularity is more, can be implanted, can be done by local surgery also. Second, and third one is the blue one that you are seeing also in the abdominal wall, and fourth one is the on the ovary, and fifth one like a millilab. It is mostly for all this remote procedure is for hormones, and the last but one is the ovarian cortex. So the journey is long and we are also successful. Oakley and all done 2001, one-step procedure. Donage et al., the renowned one for LOD, they have done first step peritoneal pocket, second step grafting. Mireo et al. 2016 mini lab and third ovary is put it there. Oakley 2017 robotic approach. And 14 et al. 2018 one-step procedure laparoscopically, no suture given and implantation is done. This is the picture which is telling how far it is effective. The green picture showing the FSH. When you implant, you will see in after the weeks, the FSH is more if the ovary is away. So if the ovary you are implanting, how the FSH is coming down, indicating the hormone milieu of the female is becoming normal. And another study showed that 34% endocrine function is active and 15 pregnancy occur after a small study. So in a meta-analysis, 267%, 190 were performed laparoscopically, 72 via laparotomy, 228 transplantation done, 195 were orthotopic, 3 were heterotopic. Orthotopic means pelvic cavity, heterotopic means different places. After implantation pelvic cavity, ovarian activity was restored about 95%. So hormone is there, then you can have a baby. Mean duration of ovarian function last after reimplantation is 4 to 5 years. So dear friends, 4 to 5 years is no less. It is so much for a female to have a fertility and that one. So now you can go for a video. You can mute it. Friends, I don't know how to thank everybody for allowing recording this one. Any doubt during the talk or anything, it will be communicated to me, and in my afterwards when I finish my exam, I'll be answering that. I don't think I'll be disturbed when I can come out from the exam. So as you know, the long cherished desire of womanhood is motherhood.
Yes, it's open for discussion.
Hello.
So thank you for patient hearing.
Hello.
You have missed my video. It was very nicely for all the students. Animation picture I loved. I was planning to present a uterine transplant, but after listening to Putembakar and everything in webinar, I came out, no, I'll not put uterine transplant. Let me find out something new, OTC or ovarian tissue cryopreservation. But please show my video afterwards. Any doubt I can clear now.
Hello, madam.
Yes.
In all cases of premature ovarian failure, we can think of this in future.
Premature ovarian failure, this is not the procedure. I told that in cases of ovarian malignancy or radiation given, or the sister, young 16 to 24 years girls suffering from Hodgkin's lymphoma or any thalassemia or bone marrow transplant or gonadotoxic agent you are giving or radiation you are giving, that time you take out the ovary and keep in a safer place in a cryopreserve in vitrification or slow freezing. After the therapy is over, you take out and re-implant in different places where there will be regeneration of the hormones and follicle, you can be pregnant. So what is the question? POF.
POF, like autoimmune thyroiditis and all in those cases.
POF, in a discordant twin, one twin develop and has ovulation and everything, other twin have a POF. So in that case, they have taken out the ovary of the twin which is fertile and implanted in the other twins which is having a POF, and she could have bear the children after that and given a live birth. That is an history. And it is also done in India, I have seen through the net, in Delhi, Mumbai and other urban centers. They are also doing ovarian preservation. See, you are preserving gonads, sperms are preserved, what madam has told, cryocan is there, everything. IVM is done also, but this is total ovary can be preserved or a cortical tissue can be preserved and reactivated after the cancer therapy is over, make the girls fertile. and there are school and they counsel. They have taken these small girls because it is very, very tiresome. So much of complications are there, other things are there. In Western countries, they have gone to schools and all girls are being counseled with their parents that they will take up this or not. They are not married, they know what is pregnancy. That time also they are counseled, they have taken the consent and done such a procedure. Previously doing laparotomy, but nowadays laparoscope robotic is so easy. And small tissue also you can implant locally in the black tubectomy. And the cortex should be in the peritoneum. So that follicle should be there, you can take it or you can do a IVF or anything else. Even normal pregnancy they can have, I told you, if the tubes are with the uterus, the ovary have taken to extrapolate, you do extrapolation in margins in young patient, you extrapolate. And why below the kidney, I told you? Because the ovary is developed from T10. It drags the vessels to the pelvis and the ovarian veins are draining to a vein or left side to the left renal vein. So up to that line only it can go from inguinal ligament to the left renal vein. So in that case, you take out the ovary and you can in the pelvis. And if you do a IVF, you can do a ovum pickup by putting a EVS, or if you can normal ovulation. Yes.
And we're running short of time now.
God bless you.
Thank you, madam. Thank you, madam. Thank you, madam.
But I am missing. I request, I profusely bless Tapan and everybody for this gesture and so much of effort you have done. Please record it so that we are, all of us in the exam, we can also listen afterwards. Okay?
Madam Namaskar, we have recorded already. Thank you.
Okay.
Thank you, madam. Thank you.
I thank all the chairs.
Thank you all. Thank you, Sadhana, madam. Thank you, Bharti, madam. Thank you all.
The information provided was highly beneficial. We'll be moving on to our next interesting.
I'll tell you, dear friends, am I audible?
Yes, ma'am, you're audible,
Please
ma'am.
make your room light off so that you will be visible nicely. When I'm switching off, there's no current now. So now it is visible mode. So to make you more visible, make the, yeah.
Thank you.
Bye-bye.
Thank you, ma'am.
Dr. Sadhana, you are coming.
One wonderful talk. I really enjoyed listening it, Dr. Bharti. It was very informative and very nicely explained, like a teacher. It is a teacher's talk. Thank you very much. It was a pleasure.
Thank you, madam. Thank you all.
Chairpersons and the speakers once again for such a wonderful session. Next up, we have an interesting panel discussion on HRT in menopause. I would like to welcome our moderator for this session, a highly renowned faculty in the field of obstetrics, Dr. SAUBHAGYA JENA. Sir, we welcome you, sir. Professor and Head of Department, AIMS Bhubaneswar. He has 52 publications for his credit, and his special interests are in minimal invasive gynecological surgery, high-risk pregnancy, and gynecological oncology. We welcome you, sir. And I request Dr. SAUBHAGYA JENA, sir, to kindly invite our panelists for the session.
Hello. Hello. Am I audible? Hello.
Yes.
Hello.
Sir.
Am I audible?
Yes, sir. You're audible, sir.
Clear?
Yes, sir.
Is my voice clear?
Yes,
okay. Thank you. Thank you for the nice introduction. So good morning to all of you and namaskar from my side. I thank the organizer for giving me this opportunity to moderate the panel discussion. So can I share my slide?
Yes, sir. Please share the slide, sir.
Yes. Is it visible now?
Yes, sir. Visible, sir.
Blank slide. One blank slide.
Yes, sir. Visible, sir.
Okay. So I am here. Is it moving?
Yes, sir. Go to your next slide, sir. Yes, sir. Moving, sir.
But it is not moving actually. When I am trying to page down button, it is not moving.
Sir, we are able to see.
Oh, yes. So I am here with blessings of Lord Jagannatha, and I pray Lord Jagannatha to bless all of us during these tough times. So here again, greetings from my institute, that is AIMS Bhubaneswar. Then I thank to the organizer for giving me this opportunity. So our topic, a panel discussion, HRT in menopause. I welcome all my esteemed panelists. First is, let me introduce Dr. CHARUBALA SAHU, who is a senior consultant in Tata Steel Medical Hospital, Kalinganagar. And her special interests are infertility and high-risk pregnancy. Then our next panelist is Dr. RADHAKANTA PANIGRAHI, who is assistant professor in SCB Medical College, Cuttack. He has more affiliations, awards, and publications. Again, special interest is infertility and gynecological endoscopic surgery. Our third panelist is Dr. VINA KUMARI, who is from Jamshedpur, and she received the Jagadeshwari Mishra Award for the best paper. And next panelist is Dr. JASMINA Begum, my colleague in AIMS Bhubaneswar. She is an assistant professor. He has many publications and special interest in high-risk pregnancy, obstetric and pelvic sonography, clinical genetics, and most importantly, she is very much interested in menopausal health. Then our last panelist is Dr. PRAMILA JENA, a professor in KIMS. She has several publications. Again, the interest is in high-risk pregnancy. I welcome, a warm welcome to all my esteemed panelists. So let me declare that I don't have any conflict of interest in this presentation. I acknowledge the efforts, but I don't have any conflict of interest. So before going to the panel discussion proper, let me remind you, all of you, just please don't forget these two things, that is mute and unmute buttons. Whenever you are trying to speak something, please mute, unmute accordingly. And be brief. I request all my panelists to be brief. We have 40 minutes with us, almost 5 minutes gone, another 35 minutes with us. And we have to be very brief. Multiple questions are there. We know, all of know it is a vast topic. So please be brief. Then objectives of this panel discussion are to give a clear, concise, and complete information. We are not going to confuse the audience. We'll give, and we'll have a blend of experience and evidence. Wherever it is possible, we'll try to give the evidence, and we'll learn from the experience of our esteemed panelists. Then the final word here is, before going to the panel discussion, is let us have a discussion. We know we have disagreement, but let us have a discussion, because I believe discussion is always better than disagreement or argument, because discussion is aimed to find out what is right, but disagreement or argument is to find out who is right. So let us find out what is right and what is not right. Let us start. Let me introduce. All of us know what is menopause, permanent cessation of menstruation due to complete cessation of the ovarian function. The terminology came from Greek. Men means month, not men, and pauses means cessation. So cessation of monthly bleeding is known as menopause. All of you know it is a phase of transition phase in life, and it is a retrospective diagnosis. And most importantly, each woman has different menopausal experience. Though there are so many symptoms, each woman has different experience. And in relation to India or developing countries, I must say that most of the women in menopausal period suffer in silence. Actually, they have so many problems, so many issues, but they open up. Actually, that is the reason individualized approach is must in this case. So my first question to my panelist, Dr. JASMINA, is how will you diagnose the menopause? Dr. JASMINA, please. Please unmute. Dr. JASMINA? Hello?
Ma'am, you are not audible, ma'am. Can you please unmute yourself, ma'am? Dr. Jasmina Begum, ma'am. Ma'am, you are not audible to us, ma'am.
Okay, any of the panelists? As we are not able to hear Dr. JASMINA.
Yeah, menopause. I am Dr. RADHAKANTA PANIGRAHI. Am I audible?
Yes, yes, yes. Please go ahead,
Yeah,
Dr.
yeah.
Radha.
Yeah, the menopause is a transition phase of female life. So how will you diagnose menopause? Menopause is clinically diagnosed. It mainly depends on the cessation of the menstruation at least 12 months. Suppose a woman is menstruating regularly, if she ceases to menstruate for 12 months, then that is called amenorrhea, and it is defined as menopause. The mean age of menopause is around 50.7 years, but nowadays it varies from around 50 to 59 years. So the diagnosis is basing on the clinical symptomatology, not the biochemical investigations. So that is the definition of menopause.
Okay, so thank you, Dr. Radha. So if I will go to the NICE 2015 guideline, it says that more than 45 years, if there is amenorrhea for more than 12 months and the woman is not using any hormonal contraception, so you can diagnose as it is a retrospective diagnosis. And if the age is more than 45 years, as Dr. Radha has mentioned, don't go for any biochemical tests. Okay. So,
Sir, am I audible now, sir?
Yes, yes, yes.
Yes,
You
sir.
want to add anything, Dr. Jasmina?
Nothing, sir. Sir, only one thing I want to add here. Like we get patient, like there is a concept like premature ovarian insufficiency. We get patient coming for fertility insufficiency, where we need biochemical testing. So it's not like only history. In that conditions, we have to exclude menopause. So we have to take help of biochemical markers. Already, I think Dr. Radhakant has told about the history-based diagnosis. Yes, it is true. It is at the late reproductive age, we have to diagnose without a biochemical marker. But when there is confusion between the fertility issues and to differentiate menopause, we have to take the help of biochemical marker. During that time, you have to take the serum FSH level. And if it is more than 40 international unit per ml, twice it is done 4 weeks apart, then we have to consider menopause, like attending premature menopause.
Okay, so I completely agree with you. Whenever the age is less than 40 years, if you are suspecting, then there is role of biochemical markers. In between 40 to 45 years, again, you may go with biochemical markers, but if the age is more than 45 years and there is 1 year amenorrhea in between and she is not using any hormone, then there is almost no role of biochemical markers, at least to diagnose the menopause, and it is symptomatology based. Okay. So there are some symptom scores list, actually different systems like Greenish score. So many scores are there, modified Greenish score, and it has been already highlighted that respond to the symptoms, specifically in menopause, not in premature menopause, respond to the symptoms, not to the biochemistry. Then my next question is to Madam Dr. Charubala Sahu. Madam, will you please tell what are the symptoms of menopause?
Thank you, sir, for giving me chances to tell. So, and thanks to our Isoparb organizer giving me a chance to say something. In case of menopause, most patients come to OPD with hot flushes, night sweat, palpitation, vaginal dryness, and fatigue, depression, and that sleeplessness due to is causes the fatigue and more loss of confidence and urinary problem, mostly incontinence of urine, not incontinence, stress incontinence, and urgency of urine, and burning sensation of urine.
Okay. Thank you, madam.
This is all symptoms.
Okay.
Common
Almost
symptoms.
it is. Our common textbooks describe that at least there are around 35 symptoms of menopause.
35 symptoms, the dizziness, and
yes, but
35
all the menopausal women does not have all these symptoms. Some symptoms are predominant in some women. So it is a symptomatic. That is the reason we should have a scoring system for symptomatology. Okay. So my next question is to Dr. Radhakanta Panigrahi. Can you briefly highlight what are the stages of reproductive aging?
So this is a straw. In 2001, they have divided the menopausal stage, that is again into 3 stages. One is that is called depending upon the symptomatology, biochemical criteria, and some of the menstrual irregularity. So what is that? They have divided into 3 phases. One is reproductive staging, another is menopausal transition, and there is a post-menopausal. The score starts from -5, ends with +2. That means the reproductive staging, again in 2010 workshop, they divided into early, that is -5, then peak, that is -4, and there is late, that is -3. Again this reproductive, again the transition to the menopausal transition, again divided into -2, -1, early menopausal transition and late menopausal transition. Again the post-menopausal phase is again divided into early menopause and late menopause, that is +1 and +2. So why they have divided into such a staging? Because they have seen that the symptomatology, like the symptoms varies from reproductive to the menopause. The menstrual irregularity varies from the reproductive age to the, that is the mid position is FMP. What is FMP? FMP is the final menstrual period, that is taken to be the 0. So from 0, this phase is known as the reproductive stage. From 0 to minus my +1 and +2 is the menopause stage. But why this happens? Because of the 2 biochemical markers, that is FSH, inhibin, and anti-Mullerian hormone. These 3 biochemical markers, along with the menstrual cycle and the symptomatology like vasomotor symptoms and urogenital atrophy, these symptoms they have taken into consideration, divided into various stages of, that is called straw +10 criteria.
Okay, thank you, Dr. Radha. Nicely described. Then moving ahead, my next question is to Dr. Veena Kumari. Madam, will you please explain what are the stages of menopause, and are there any Indian guidelines or any Indian person has described regarding stages of menopause? Yes, please go ahead.
Good morning.
Good morning. Good morning.
Again, the same like straw staging has only given as the staging of reproductive aging workshop criteria, wherein the stages of menopause are like early menopause transition, the late menopause transition, early post-menopause, and late post-menopause. So first is the late reproductive stage, which is marked by decreased fertility and onset of menstrual cycle changes. And early menopause transition, which is increased variability in menstrual cycle, where the cycle lengths are more than 7 days. Late menopause transition, when there is amenorrhea of more than equal to 60 days. And early post-menopause, wherein approximately 5 to 8 years after final menstrual period, and which is then followed by the late menopause. It is also like stage 1 can also be divided, as you have already shown in the slide. Stage 1, stage 2A, which is confirmation, that is one after 12 months of amenorrhea. Stage 2B, which is up to 5 years after menopause, and stage 3 is from 5 years after menopause to her lifetime.
Okay, thank you very much, madam. Yeah. Then my next question is to Pramila, madam. Madam, what do you think? What are the issues in menopause?
Hello, good morning. Am I audible to all?
Yes, yes, madam. You are audible.
Main issues of menopause are number one, the vasomotor symptom, which is very bothersome, night sweat and the hot flashes, and that decreases the sleep and greatly affects the quality of life of a menopausal lady. And the second bothersome problem is the urogenital problem, that is the urogenital atrophy, vaginal dryness, loss of libido. Again, that affects their sexual life as well as the quality of life. And the most important is the risk of osteoporosis, and mostly this risk is increased towards the late menopause, even though not much increase in early menopause. And the last one is the cognitive function, like the irritability, mood disturbance and all. And we know all these thing affects a lot the quality of life of a postmenopausal and perimenopausal lady. But to prescribe them HRT, again we have also few issues like the medical comorbidity, like many of them having the pre-cancer, like history of breast cancer, endometrial cancer, somebody might be treated with that. And in those category of cases, we also face a lot of difficulty while prescribing HRT. That is, those are the issues, I think.
Okay, okay. Thank you very much, madam. Then any panelist can tell what is the role of physician in menopause. Actually. What is our role?
Can I say? So the role of physician is not to treat the symptoms, but to counsel the patient.
Very nice.
One is number one is menopause. It's just like a pivotal changes. You have to think menopause. If you are at the age of 40, say about 50, somebody thinks that my menstrual cycle gone, my fertility problems gone. So negative thinkings creeping into the mind. So you have to counsel the patient. This is a transition phase of the life, just like a pivotal changes. So negative thinking should be counsel that this should not have your negative feelings. So first, let's treat the symptoms. The most important thing is prevent menopause. How to prevent? If the patient is symptomatic, treat the symptoms. If the patient is asymptomatic, counsel the patient for future problems. And the most important is prevention of the menopause. How to prevent? You have to think that positive attitude, prevention of the stress, taking care of the bones, taking care of the genital organs, taking care of the CNS cognitive and mood disturbances, and their sleep problems, appetite, regarding old age problems like frailty and all those things, and sarcopenic. So if the body mass index is low, if the patient is having some stress, you have to counsel that these are the stressors or these are the factors which you can prevent and prevent the menopause.
Okay, thank you, Dr. Radha. So having a brief idea on menopause, let us go on very fast to the first case actually. So this is a case. Let me tell regarding this case. Mr. X, 54 years, para 3 live-in thing. She has been trouble in sleeping and experiencing severe hot flushes. Her height is 5 feet 3 inch, weight 75 kg, history of hypertension, high cholesterol. Her family history includes diabetes and cardiovascular disease. Her mother had a venous thromboembolism at the age of 52 years following a serious car accident. Her chart shows that her last menstrual period was having 5 years back, and she states that she's tired of having these hot flushes. So with this background, may I ask the questions to Charubala madam? How are you going to evaluate her, madam? Please be brief, madam.
Yes, sir. She is hypercholesteremia there, and she is hypertension. So she is most probably we should exclude her heart attack and stroke. It's the first thing we have to exclude. Okay. Then so this is clinically we have to exclude.
Yes.
And any problem yes.
Have a holistic approach. That means don't go into the symptomatology. See the patient overall. Take a proper medical history.
Yes.
Do an examination. Examine the breast. Have a pelvic examination. And you try to find out, as Dr. Radha has already mentioned, what is the woman's need. And and other risk factors. Okay. Thank you, madam. Then to Dr. VINA, what are the investigations required in such a case?
Sir, for the investigations which are required, like first the questions we need to ask, holistic approach as you are telling. So we need to know about her past, current medical history, family history, her lifestyle factors, that is use of smoking, alcohol, exercise, and any concurrent medication that she's taking. Along with that, the examinations and investigations that we need to do are, we have to see her body weight, that whether she's obese and what is her BMI. Then her blood pressure should be measured, blood tests. If
please focus on investigations only, history, clinical evaluation.
Sir, imaging like ultrasound, bone density if indicated by response to questioning, mammography if it has not been performed, and bone densitometry, that is dual dual energy X-ray absorptiometry if the patient is at risk of osteoporosis.
Okay, so there are some investigation like CBC, blood sugar estimation, pap smear, transvaginal sonography, and measuring the intraocular pressure.
These are the basic investigations.
Basic investigations were required, and when it is indicated, we have to go for investigations, other investigations as mentioned.
Right.
But remember, all investigations are not mandatory, and choose judiciously and individualize the investigation. There is not a battery of investigation you must have to do. Thank you. Thank you.
Sir.
Okay, so my next question is Dr. Radha. What are the management options for this case?
So she's number one is she's having some first is counsel the patient. Proper counseling is very important. Number one is she's obese. I think she's obese because the body mass index is very high. So first is weight reduction regarding dietary prescription. The dietary lifestyle she has to change, and exercise is a very good, either weight bearing exercise or isotonic exercise like walking, morning walk, cycling, swimming, and all those things. And third one is very good in older age is immunization. Regarding immunization, nowadays they should be preventable, like today coronavirus, influenza, and all those. Immunization is a very important part to prevent and older age problems. Second, the most important is pharmacotherapy. Which therapy you should give? Number one is her she is having altered physical parameters of these things. So we must individualize the treatment, which kind of hormone treatment we should give, and which kind of suppose combination therapy or estrogen therapy regarding the or tibolon therapy. So we have to individualize according to the symptomatic needs.
Okay. Thank you, Dr. Radha. There may be pharmacotherapy is hormonal and non-hormonal. So to Dr. Jasmina, what is hormone therapy actually in menopause? What is hormone therapy? Dr. Jasmina?
Sir, in menopause, am I audible, sir?
Yeah. Please go ahead.
Hormone therapy, that means you are giving exogenous hormone in a less than physiological level. So in a lowest dose. So whatever the physiological levels are there in the reproductive age group, it is below that level you are giving. That is below the level of physiological range you are giving. So that is not going to do any harm to the patient until unless patient is having some risk factors or the established disease is there. So
okay. What are the different types of the hormone therapy? We tell it is a HRT. Previously, we were telling HRT. Now the accepted terminology is menopausal MHT or HT. Menopausal, the preferred terminology is menopausal hormone therapy. What are the different types of menopausal hormone therapy?
Sir, now the term is menopausal hormone therapy, where you have to give estrogen. Estrogens are available in the different forms, like conjugated equinestrogen is there. 17 beta estradiol is there.
We'll come to that. We'll come to that in a minute. So either estrogen or estrogen progesterone combination, or sometimes if it is required, you can give androgen or tibolon. Yes. Thank you.
Yes,
then coming to the next case, actually, a 53-year-old menopause, non-obese menopausal woman having menopausal symptoms. Her mother had a breast cancer actually. So, and she is worried regarding this hormone therapy. My question is, this is a common issue. Even this is worrisome for the healthcare providers, not only to the patient. So, my next question is to Pramila madam. What is the trend of hormone replacement therapy over the decades actually?
Well, excuse me. Hormone replacement therapy first used in 1920, and I think the use of hormone replacement therapy is popular in the 1990 till 2000 because many observational studies have recognized that the hormone replacement therapy has several benefits like the cardioprotective effect, protection from osteoporosis, and benefit regarding the Alzheimer's disease. They think they improve the Alzheimer's disease and improve the quality of life and the longevity, and the risk were few, like it increases the risk of the breast cancer, ovarian cancer. So the HRT use was increased during that time until the year 2002-2003, when the study of the WHI, that is the Women Health Initiative, largest RCT on HRT, and the Million Women study, and the result of the HER study, that is the heart estrogen progesterone, published, and they say that the HRT is no more a cardioprotective effect. So after the discovery of these things, and they also stated that the risk of stroke, the risk of cardiovascular disease increased, risk of thromboembolic episodes are increased, and risk of ovarian cancer, endometrial cancer increased, and only benefit was the protection from osteoporosis and the protection from the colorectal cancer. So we said the HRT,
it was increased, then it is decreased. Suddenly after the WHI trial. Okay.
Then we have started using the HRT cautiously, and the newer study like the DOPS and the ELITE study, and I think another is a
okay. Okay, madam.
Say that if you use HRT in early menopause, then the risk of cardiac
okay. The trend was it gradually increased. It peaked around the 2000, and suddenly after that WHO trial results came out, which was closed prematurely.
Initially it was the estrogen hormone they are using. When the progesterone came into force, there was a peak. Again, because it was declining because of the WHO trial. So first estrogen, then progesterone added, then WHO trial, then it is tending towards it is a decreasing trend nowadays because of so many complications.
We restrict ourselves to the early menopause, and we extract all the benefit without any increase in the cardiac side effect.
Okay, okay, we'll come to that, madam. If time permits, we'll come to that. So my next question is to Dr. Jasmina. Why suddenly the number of postmenopausal women, though some parts is answered actually, has suddenly decreased actually?
Hello.
Yes.
Am I audible, sir?
Yes, yes.
Okay. So already, like most of the things were answered by Pramila madam. So why then suddenly?
Just a highlight. Just highlight. Yes.
This is after WHI trial result. So which has shown the risk is more than that of the benefit amongst certain conditions like coronary heart disease, stroke, pulmonary embolism, breast cancers. So there is increase in risk outweighs the benefit in this condition. So because of that, in the combination arm, that is estrogen progesterone arm, and also in the estrogen arm itself, it has shown that there is increase in hazards ratio for stroke and venous thromboembolism. Because of that publicity by the journalist, it has created panicness among the users and also the physician. So as a result, there is sudden drop in the use of HRT by the patient, but also it was suddenly dropped by the physician prescribing the drugs.
Okay, okay. Thank you, Dr. Jasmina. So my next question is to Dr. Bina. How will you express the frequency of a drug reaction? Because it was the adverse reaction of the estrogen which caused all the problems actually. So how we are going to express the adverse drug reactions?
Sir, the adverse drug reactions, that is the estrogen reactions, like we have...
no, in general, I'm asking in general actually, whether it is common, uncommon, or rare or very rare, if you are using any medication.
So the reactions are very rare. because the reactions and the side effects are two different things, sir. Reactions
Okay.
are the immediate effects which we get from the drug. That can be the patient complaining of bloating or breast swelling or tenderness, headaches, mood changes, nausea, vaginal bleeding, and all those things. And the side effects of a long intake can be said as a relative risk and an absolute risk, and they're very, very less, because although the absolute
So-
risk of is
my point is how, if you are counseling a woman or postmenopausal lady, if they are asking regarding the risk of or adverse frequency of drug reaction, how can we explain them in a common language or colloquial language?
Sir, we have to explain that if it is taken for the shortest duration and for the minimal time, then it has got very less side effects. But if it is taken for a long duration, then of course it does have effects, or long hormone therapy does have effects on the breast cancer and endometrial cancer.
Okay,
Especially
thank you.
if it is not given along with progesterone.
Okay, nice. Then next question is to Dr. Radha. Briefly, please describe what is this, that was the main outcome of the WHI study, but when it was subgroup analysis was done, what was the outcome?
After the WHI study, it was found that the estrogen causing the venous thromboembolism, the stroke is very rare. So what is the advantage of, there are two answers, one is estrogen R, another is estrogen plus progesterone R. So in estrogen progesterone R, according to the WHO study, if you take a venous thromboembolism, that is very high. But in estrogen progesterone R, the venous thromboembolism is very rare, because if you are adding progesterone, it is decreasing. So again, the estrogen preventing stroke, only estrogen has a very good effect in preventing the stroke, and estrogen also prevents the bone resorption, that is osteoporosis is prevented. So finally it was found that estrogen, in a WHO study, it was found that estrogen doesn't prevent any coronary heart diseases, and estrogen does not improve any cognitive function or stroke or dementia, but it prevents osteoporosis. So these are the
WHI study was done almost in a larger age group. It started from 50 to 79. But when the subgroup analysis was done according to the age, it was found that in the age group of 50 to 90, that is, sorry, 50 to 59, or less than 60, or if it is used within 10 years of the stoppage of menstruation,
then it is a beneficial effect rather than side effect.
Rather than all the complications which was mentioned, either a 1-year follow-up or a 5-year follow-up was not so high as it was highlighted by the media or public in relation to the WHI trial.
Yes.
Okay, Madam Charubala, Madam, will you please tell what are the safety profile and indications of HRT? How safe it is and what are the common indications?
Yes, sir. Safety, it is only estrogen, that is estradiol, and it is a very safety. But WHI study says that 2021, it is a very safety drug. You can give, but orally you can give, but it has a so benefit than risk. So it should be given less than 60 years, but it can be given 5 to 10 years. And but this is its benefit is more. If it is estradiol is added with micronized progesterone, then profile is this safety profile is more. And the common indication is our GSM and that vasomotor symptoms and osteoporosis, that one mood variation, sleep disturbance, depression. But most commonly used, we used hot flushes more, because it is the most common complaint, and vaginal dryness also.
Okay.
And vaginal dryness because of sex discomfort.
Yes, yes. My next question is to Dr. Radha. I think. What are the different types of estrogen and progesterone preparations used in HRT?
So the estrogens are usually we use is conjugated equine estrogen, that natural estrogens. So conjugated conjugated estrogen is a synthetic, and micronized estradiol. So estradiol, which we are using, ethinyl estradiol is not used here. Only estradiol valerate and ethinyl estradiol is lessly used. And the natural estrone, estradiol, estriol, estrol, E4, they are also used. But the progesterone we are using mostly is medroxyprogesterone acetate, norethistran and norethindran. And you can use also natural micronized progesterone. But nowadays we are also using the levonorgestrel IUS like the Mirena, and drosperinon also used, and the Dynogest is used as a progesterone preparation. So the broadly conjugated equine estrogen and estradiol valerate are used in estrogen preparation. Medroxyprogesterone acetate and natural micronized progesterone are mostly used in progesterone preparations.
Okay, thank you, thank you. Then what are the different routes, madam? Charubala, madam?
Yes, sir. This is oral.
Yes.
Roots. Yeah.
Yes, madam.
Orally
Go ahead.
can give orally and transdermally, subcutaneously, and vaginally. But in transdermal is the more intranasally also, but now
orally, transdermally, and vaginally commonly. Yes, madam.
Transdermally is very effective as a transdermally is very effective as a gel, spray, and cream, and it is the lowest dose we can give, and patient will be get benefited even after 60 years, as IMS says.
Okay, okay. Thank you, madam. What are the different dosage results, Dr. Bina, specifically in relation to estrogen?
So there are two dosage schedules actually, cyclical or sequential and continuous. In cyclical or sequential, the pills are taken every day for a set number of days. And a higher dose than that used in continuous dose of progesterone is given for 10 to 14 days.
Okay. That is if when you are using in combination.
Yes, sir.
Either sequentially or cyclically. Okay.
Yes,
but in relation to the dose of estrogen, it has been told that it is a standard dose, low dose, and ultra low dose. So, standard dose is conjugated estrogen 0.6.
Yes, sir.
0.625.
0.625 milligram per day of conjugated estrogen or 1 milligram per day of micronized estradiol. Or if we are giving it transdermally, then only 0.05 milligram per day is sufficient. And if we are giving it in low dose, then 0.3 to 0.45 milligram per day of conjugated estrogen or micronized estradiol can be given as 0.5 milligram per day. And in transdermal, the dose is even less, that is 0.025 milligram per day.
Okay, okay. Thank you, madam. So next question is to Dr. Pramila, madam. Here comes an important hypothesis that is known as timing hypothesis. Will you please describe, madam, what is mean by this timing hypothesis?
Timing hypothesis means like from the subgroup, as we have already discussed from the subgroup analysis of WHI, and in addition to that, there are few more recent RCT, like one Danish study, like that is DOPS, and one Kronos study, that is KIPS, and another one the late versus early menopause allied study. The three RCT altogether, they confirm that if we use the window opportunity of using HRT in early menopause, close to menopause, like within 10 years, maybe less than 60 years, then the benefits can be explored without increasing the risk of HRT. That is, I think, the timing hypothesis. And
yes,
if we go far beyond the menopause and use HRT, then the risks are many. So we should always try to avail this window opportunity to help the lady with the HRT. So first 10 years, that is less than 60 years, is safe, and few study also says that they have the cardioprotective effect. Maybe they are in this window.
Yes, thank you. Thank you, madam. Then what are the different indications, Dr. Radha? Already it has been highlighted. Just
so the I must tell
briefly.
that it is symptomatic. If the patient is symptomatic, use the lowest dose. Dose, maximum benefit, no harm to the patient. The symptoms are vasomotor symptoms, genitourinary symptoms, osteoporosis, and depression. Sometimes we may use in asymptomatic cases, but the main nowadays HRT also can be used in premature ovarian insufficiency. That is one area where you can get the maximum benefit by supplementing the HRT. And the one is regarding osteoporosis. It has shown that either you can Tibolon or HRT, both prevent osteoporosis in a very good effective way. But regarding the coronary heart diseases, the HRT, use of HRT is still controversial. So
Yes.
Madam has already told that that is timing hypothesis. If you supplement the estrogen in the early phase of menopause, that may prevent coronary heart disease. But these are the indications of using HRT, mainly because these 4 indications like vasomotor, GSM, osteoporosis, and depression.
Okay, thank you, Dr. Radha. Then benefits, can you tell me?
So the benefits are multi-pronged. It is suppose the benefits are, if you are using HRT, I am telling that, so lowest dose, maximum benefit, no harm to the patient. So it decreases the type 2 diabetes mellitus. Sometimes the possibility also prevents the abdominal obesity, helps in preventing the osteoporosis, increases the memory, that is cognitive function, and neurovascular, like sometimes like the frailty symptoms. So the postural disturbance, they also prevent, and improves the quality of life. Very important is the quality of life. Suppose a patient is having vasomotor symptoms, say about genitourinary atrophic symptoms, urinary incontinence. After giving either transdermal preparation or vaginal application of the estradiol, these prevents are very much they prevent these symptoms, and the patient improves a lot.
Okay, thank you. So my next question is to Dr. Jasmina. What is the cardiovascular risk of HRT? Because that is the biggest fear actually. One is cancer, venous thromboembolism, another is the cardiovascular risk, cardiac heart actually health. So can you tell me what are the cardiovascular risks and
Okay,
how
sir.
will you segregate the patients?
Okay, so cardiovascular risk is also, it is applicable like timing hypothesis. Once the disease is started or established, it is going to aggravate the disease. So basically, once the age is more than 60, or if the menopause is more than 10 years, if you're starting HRT or MHT, then it will causes more cardiac disease like MI. There is increased risk of MI. There is increased risk of coronary calcification of the vessels of coronary artery disease will be there. And there will be increased risk of stroke. So these are the cardiac diseases will be increased after somebody doesn't follows the timing hypothesis.
Okay, thank you.
I must one thing tell, if there is already a stable plaque formation has occurred, if you are supplementing HRT, you are going to do more harm rather than having benefit. So if the plaque is unstable, in a case of atherosclerosis, if the unstable plaque is there, and the plaque can be dissolved by being HRT, then it is going to benefit the patient rather than doing harm. So this is all.
Okay, so as the time is short, we cannot discuss it in detail. Let us go ahead. So, Charubala madam, what is the risk of venous thromboembolism with HRT?
Yes, sir. Venous thromboembolism is there with estradiol, but it is more when we are giving orally. When you are giving transdermal, so it is circulation, it will not go to our circulation, and it will be less. So,
and it is more less in Asian women also, madam.
Yes.
As compared to Western women, this is very less in Western Asian women. Okay,
so that,
okay.
Only for that.
Then cancers, Dr. Bina, can you the relationship between HRT and cancers?
Yes, of course. So coming to breast cancer first, the use of estrogen alone and estrogen plus progestin has been reported to result in an increase in
Yes, madam.
Increase in abnormal mammograms requiring further evaluation, and hence whenever we prescribe hormone replacement therapy to any female, the women is asked to take like annual clinical breast exam, perform monthly self-examinations, and regular mammograms are recommended in such patients. Other than that, coming to the ovarian cancer, estradiol products as such are contraindicated in women with estrogen-dependent neoplasms. But coming to the WHI trial, the relative risk associated with current risk of hormonal therapy was only 1.41. So there has not been much like risk of ovarian cancer is less, but of course in estrogen dependent neoplasm, the HRT is contraindicated. Coming to the endometrial cancer, estrogen therapy per se is contraindicated in patients with known estrogen dependent malignancies, and also unopposed estrogen therapy
Sorry to interrupt,
should not be
sir.
given.
We're running short of time, sir.
Okay.
Thank
Okay.
you.
I'll summarize, madam. Yes. Thank you.
Yes, sir, please.
Okay. So these are some issues. Then to summarize, yes, it is very much helpful in vasomotor symptoms and genitourinary symptoms. It may improve joint and muscle pain, in mood disturbances, sleep disturbances. But we have to remember that it has to be individualized and tailor-made. Start with a dose which can reduce the symptoms, then gradually go down. But it is not the only treatment. It should be a part of overall strategy, and already other parts has been described. But the take-home message is what I want to give is lowest dose and shortest period versus appropriate dose. Try to give the lowest effective dose. Again, I repeat, lowest effective dose. Giving just a lowest dose which is not effective is not helpful in any way. Try to give a lowest effective dose, individualized, shared decision making, and periodic re-evaluation. So to conclude, yes, hormonal therapy is very much helpful in postmenopausal women if it has been decided properly, taking in the risks and benefit. That means there is nothing more wonderful than always feeling young at any age. I thank my panelists for a nice and interactive discussion, and again thank the organizers for giving me this opportunity. Thank you very much. Over to the organizers.
Thank you, Saubhagya bhai. You are a nice moderator. Thank you, organizers, for giving this opportunity.
Please log into Hall A. Please log into Hall A. Oration has started. Please log into Hall A. All of you are requested to go to Hall A for conference oration.
We thank you, sir. I thank all the panelists for providing us such insightful information on this topic, and Dr. Saubhagya Kumar JENA for beautifully moderating this session. Thank you so much, sir. I request all the delegates to join Hall A for the oration. We'll resume our session at 2 p.m. in Hall B, sir. Yes, all the delegates are requested to join Hall A for the oration on bridging the gaps in healthcare by Dr. Suchitra N. Pandit. Kindly join Hall A, and our session will resume at 2 p.m. Yeah, requesting all the delegates to kindly move to Hall A for our oration. Requesting all the delegates to kindly move to Hall A for the oration session by Dr. Suchitra N. Pandit. We'll be resuming our session at 2 p.m. in Hall B.